name is changed, subsequent to which the meetings will be held in Chandigarh, in Bangalore, in Ahmedabad, in Srinagar, and Kochi. And I must congratulate the laudable efforts led by the INSL executive as well as Dr. Ashish Kumar, whom you all know, who is instrumental in organizing these clinics. And the purpose of this clinic is to provide to the clinician, particularly the gastroenterologist and hepatologist, as well as the oncologist, interventional radiologist, as well as radiation oncologist, who are dealing with this group of patients, the state-of-art informations, and how a teamwork, because today the therapeutic advances in treatment of liver cancers, starting from curative to effective palliative therapy in advanced cancer, has tremendously advanced. And it is probably very difficult on a single part or a single consultant or a single specialty belonging to one discipline to have a grip on the huge knowledge and variable knowledge that has been accrued during particularly 2 decades. It's a tumor which was previously thought to have abysmal prognosis, and today is being claimed to be curable. Because you know, in liver cancer, there are curable therapies like transplant, ablation, and surgeries. So it's one of the cancer that is being curable, provided you detect in an appropriate stage and provide appropriate therapy with appropriate supportive treatment. And that needs not only inputs, that needs a teamwork. To do that, Dr. Ashish and the INSL team has collated effective faculty, each of whom are very eminent and very expert and very knowledgeable. And on behalf of INSL, I also convey my heartfelt gratitude to all the faculty, starting from Professor Abhijit Chaudhary, Prasant Bangoi, Dr. Usha Goenka, Dr. Dipanjan Panda. Of course, I have thanked Ashish. And I can see very knowledgeable people sitting in the audience. And to name them, I always tell first Dr. Mahesh Goenka. I think he is a man who has inputs from all disciplines, starting from AI to medicine to everything. I can see Dr. Kingsuk Das, Dr. Karambir Chakravarti, and other stalwarts. And thank you, sirs. Thank you very much for encouraging INSL. I will not waste the time. I will first start the ball rolling by asking Ashish to give the introduction to the course and how and why it has been designed so with a purpose. Dr. Ashish. And before that, we as usual, traditionally we do a lamp lighting, and I will invite all the faculties and all senior members, Abhijit, Prasant, Dr. Kingsuk, Dr. Karambir Chakravarti, Mahesh, Ma'am Goenka, Ashish, all of you to come and kindly, Dr. Panda sitting there. You don't mind if I'm forgetting the names. With age, you know all doctors, the biology is decreased cerebral blood flow, unnecessary cortical atrophy, and amnesia. So it is natural. Okay, please come.
या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
Thank you, Dr. Acharya, for that welcome address. So I would tell briefly why we started this Inasl liver clinics, HCC clinics in 6 cities. The treatment landscape of no other disease has changed so much as much of HCC in last couple of years. Till about a decade ago, HCC was considered one of the very dismal prognosis cancer with very poor survival rates. But over the last about 10 years, the treatment of HCC has dramatically changed. Now we have so many drugs which have increased the survival. We have tyrosine kinase inhibitors, we have immune checkpoint inhibitors. The loco-regional therapy has dramatically changed from ablation with alcohol. Now we have microwave, we have TACE, we have TARE, and now SBRT or radiotherapy has been come into place. Then the transplant landscape has also changed. Now patients who were deemed inoperable or uncurable, now with downstaging therapies, the transplant has changed so much. So over last 1 decade, there's been so much change in the treatment landscape of HCC that it's very difficult for any practicing gastroenterologist to keep update. Every few months, new drugs are being launched and newer therapies are there, combination therapies. So we decided that to keep update, one thing which we did was we published our HCC guidelines. The first Indian guidelines were published in 2014 under chairmanship of Dr. Acharya. Subsequently, we had an update in 2019, which were published into 2020. And now we have come up with the 3rd edition of these guidelines, which will soon be out in the JCH within a couple of months. So apart from guidelines, we also need to increase the awareness of the treating physicians and gastroenterologists, hepatologists and surgeons all over India. And instead of having one meeting where we talk everything at one place, we decided to reach out to more and more people at different cities. So we decided to have these single theme symposiums at 6 cities to start with, where we would discuss each aspect of HCC, starting from diagnosis, screening of HCC, diagnosis, and loco-regional therapy, transplant, and management. And instead of talking about very advanced things, we would talk only about what are clinically relevant and day-to-day problems, what we face, and how we manage these patients. So we would have case-based discussion and simple algorithms like how we diagnose these patients, how we should when to refer for loco-regional therapy, when to refer for transplant, and what to expect. And not only that, we'll also discuss the guidelines which we'll publish, and plus in the case-based discussion, we would also have practical scenarios which we faced in day-to-day life. So, so we decided to have these 6 symposiums at 6 different cities, and we also decided for those people who are not able to attend, we decided that we would have it YouTube live, so that more and more people can see these proceedings. And also being in YouTube, it will be there forever. So whenever any student or anyone wants to refer to, they can go through this. So this was the basic purpose of these Inasl clinics on HCC. And we also, going from city to city also actually involved multidisciplinary approach. We invited radiologists, we invited surgeons, hepatologists, and physicians, all of them to take part in these multidisciplinary meetings, so that more and more awareness can be generated through these meetings. So this was the basic introduction of the course, and we have lined up 6 topics. The first one is about mainly screening of HCC in patients with cirrhosis, what is new about it, which would be covered by Dr. Abhijit Chaudhary. So HCC is a disease where two simultaneous etiologies are killing the patient. One is the liver disease, which is with decompensation, hepatic encephalopathy, ascites, AKI is trying to pull down the patient. Then if with the HCC together with its spread in portal vein thrombosis and metastasis, this also so it's the treatment of HCC in these patients is very difficult. So it is always better if early diagnosis of these patients is there. And so for that matter, because we have a predisposing population of cirrhosis and hepatitis B and patients with chronic liver disease, so it's mandatory that we detect these patients as early as possible so that actually curative treatment is possible. So screening and timely diagnosis of these patients is very essential. So the first topic would be of screening and early diagnosis. The next is, once we have diagnosed these patients, how should we stage? Because the staging, the standard staging which has been followed all over the world has been the BCLC staging, and that has also changed over the period of time. Now the BCLC has updated in 2022 its staging. And apart from BCLC, there are many other staging. So which staging should be followed in Indian patients? Which there are Hong Kong staging, TNM staging, there are so many other staging. Which is better and most suited for Indian patients? That would be discussed by Dr. Acharya in his talk. The next would be about transplant. The transplant scenario has changed so much in last couple of years that I was just discussing this with Dr. Prashant, that in last about 5 to 7 years, the transplant scenario in India has dramatically changed, and there's been exponential growth from about 20 or 30 odd centers a few years ago. Now we have hundreds of centers, and we are the second most transplant centers in the world now after USA. So, and many of these patients need transplant if they are detected early, and if they are detected late also, then there's possibility that we can downstage these patients and still transplant these patients and have very good survival. And in India, live LDLT program is very well and running. So which patient should be subjected to LDLT? Should we, because the scenario of LDLT is different from DDLT, where the transplant criteria are very restrictive, like UCSF or Milan. But in India, being LDLT program, more generous transplant criteria can be adopted. So this would be covered by Dr. Prashant. Next is the loco-regional therapy, which would be covered by Dr. Usha. There's been so much change in loco-regional therapy in last few years. For ablation from radiofrequency ablation, now we have changed to microwave ablation. We are doing tastes in super selective tastes, DEB tastes, and many other modalities have come up. The Y90 radio embolization has taken over in many centers. And then radiotherapy or SBRT has also come up. So all these nitty-gritties of loco-regional therapies would be covered by Dr. Usha Goenka. And subsequently, systemic therapy would be covered by Dr. Dipanjan Panda. In recent 4 to 5 years, there's been a lot of changes in systemic therapy scenario. From 2007 and 2008, only one drug was there, that was sorafenib, then came lenvatinib. But over the last 4 or 5 years, there's so many drugs have come, tyrosine kinase inhibitors, immune checkpoint inhibitors. Now people are talking about only single agent immune checkpoint inhibitor as therapy for HCC. So lots of change. Now we have first line agents, second line agents, third line agents, all these nitty-gritties of systemic therapy would be covered by Dr. Dipanjan Panda. And lastly, I would try to present 2 or 3 cases where I would present real life scenarios how difficult it is when these patients come to our clinics to take a decision what to do, how to stage these patients, and how to manage these patients, and how to transplant, or how to do their downstaging, and what to do if there's certain side effects of these treatments. So I would try to cover these, and I would also cover applying these treatment decisions based on the recent guidelines published at many from many societies, including India, in Inasl guidelines. So without wasting much time, I think I would begin. And the first session would be on screening and early diagnosis. And for this, I would invite the moderator of the session, Dr. Vikas Prakash, to come on the dais. The chairpersons are Dr. Pratik Poddar, Dr. Anirban Chatterjee, and Dr. Pradipta Kumar Sethi. I request all the chairpersons to come to the dais, and I request the moderator to introduce the speaker for the first session, that is screening and early diagnosis of HCC. So, Dr. Vikas.
For the first talk, I would like to request Dr. Abhijit Chaudhary. He is professor in Institute of Liver and Digestive Sciences, Kolkata, Sonarpur. Sir.
Thank you. Very good evening. I'm really glad that INSL has taken this initiative, and I think this is very timely, as Ashish and Professor Acharya has pointed out. So what I'm going to do is I'm going to talk on the principles, what's old, and then very briefly, and then I'm going to take over to really exciting new stories that are coming up. And at the very outset, I want to emphasize that as Professor Acharya initially mentioned, and Ashish has pointed out, that significant amount of enthusiasm is visible, perceptible, and all of us know in the area of drug development, curative therapies, and all the modalities for therapy. And the basis of that, the basis of all these therapies is to improve survival. And the primary hunch in improving the survival remains in the early detection and screening of people with cirrhosis of liver. And that's precisely what I'm going to tell you. But before doing that, let me emphasize that the idea of cancer screening first started off with colorectal cancer screening when Bert Vogelstein delineated the very meticulous journey of development of colorectal cancers based on some genetic aberrations. So, and people started realizing that you can really look at screening and detect cancers early so that they can be detected very effectively. And this is a more than 3 decades old story. After that, we know we have got very organized cancer screening strategies in breast cancer and all. And now we are talking, when we talk of HCC, we need to understand that the premises are different. In colorectal cancer or breast cancer, you are dealing with an explosion in a bright sky. But let me emphasize that when you deal with an HCC, in 90% of the circumstances, you are dealing with the circumstances where you have got already existing a very organized leafy green garden that has been converted into a rubbles on which initially gravels, then pebbles, then stones, and finally rocks appear. So your job and our job is to find out those pebbles and gravels before they become rocks and they give the dismal prognosis that we keep on talking that. While doing that, we need to understand that HCC development is a multi-stage process. There is an accumulation of genetic aberrations, both somatic and germline aberrations, and it's a long-drawn process. It's not a day's event. So earlier you detect it, so the better it is. And the changes also, there is significant amount of heterogeneity. The changes differ from tumor to tumor, differ from individual to individual, depending on many factors, and varies according to etiology, as I'll discuss subsequently. And all these are as we all have come to know, because we know the genetic changes, and every tumor is a heap of genetic changes, and it's not as simple and mathematical as Vogelstein hypothesized for colorectal cancer. So it's pretty complex. So what we need to understand is, if you can detect a cancer early, and by early detection we say less than 3 centimeter cancer, or some people say less than 2 centimeter cancer, then in a cirrhotic liver, then we are going to have a 5-year prognosis which is more than 70%. But unfortunately, even today, under the best of the circumstances, in India it's almost certain that we detect cancers when they are expanded to the phase of symptomatic, and then the median survival is less than 1.5 years and all. So it's all to improve the prognosis, early detection, and small nodules and small tumors are to be picked up, and that's the aim. And that's what I'm going to discuss with you. And while doing so, I'm going to tell you the old story. And it's whenever I talk of anything old, this Ernest Hemingway's Old Man and the Sea comes to my mind. You know, the old man used to sail his boat in the deep sea without knowing where he is going. He used to have the pleasure of doing that. And he used to have a harpoon in hand, which he used to target whenever the sharks used to come to him. Now we have got a harpoon in hand. We had a harpoon in hand initially, but we don't know where the shark lies. That's the problem. And with that, what is the old story? We know the old story. It all started, around 1990s, and this was the first paper that changed our ideas and told us that screening by ultrasound really improves the survival. You detect cancers early. That improves the reward in terms of curative intent, like, people are more amenable to curative surgeries, and most remarkably, that improves the survival. This was a 2004 paper, and that changed the ideas of cancer screening in hepatocellular cancer. And they showed that the survival can increase up to 37% if you have got a good ultrasound, but this was in hepatitis B virus cancer people in Taiwan, and then they showed, and after that came this screening. And now, Amit Singhal and all these people have done a grand review, meta-analysis and review in PLOS Medicine in 2014 to show that this is a meta-analysis of all the studies done, and that showed that if you can detect this early by ultrasound and alpha-fetoprotein, then you have got a early detection, which is odds ratio is pretty high, more than 3. You have got a curative therapy can be applied, and that's also very high, and you improve the survival. So it's fairly established that you can do that with ultrasound and alpha-fetoprotein. And now we know that how sensitive they are. For any screening strategy, your primary intent is to be sensitive. You need to pick up it early, and then enrich this by other certifying things, like we know contrast enhanced imaging or biopsies are the best modalities to prove that. So, but we know that ultrasound alone have got a sensitivity which is around 45 to 50%, not more than that. If you add alpha-fetoprotein to that in people in a population of cirrhosis, then you run up to 65%, but not more than that. And so you are still short of a fair large number of people whom you would love to target. So you run out of sensitivity and where your problem lies. So what are the lessons learned over the initial 3 decades of HCC screening? The torch that you use seems to be less than optimally accurate to be useful and high yielding, ultrasound and alpha-fetoprotein. Most important and very importantly, the turf on which the HCC develops is changing. And we all keep on saying that my HBV patient on therapy, I keep on telling that your HCC risk is reduced, but you are not out of the hook. So you can still develop HCC. And most of the cancers in HBV develops in people who are on nucleotide therapy, because almost all people who are in therapy are DNA suppressed, and then still they can develop therapy. HCV, post-SVR cirrhotics, they have been shown to be. And very importantly, the largest chunk is NAFLD and alcohol. And that's expanding globally. So you have got NAFLD and alcohol people who are increasing. Very interestingly, even in United States, where you have got a very streamlined and, insurance-based strategies, acceptance of screening is very low. It's less than 30%. With this ultrasound and alpha-fetoprotein modalities, health system integration is very poor. Keep apart Indian health system integration thoughts. It's in the United States. And the cost and the harm are the flip side. The cost effectiveness, ultrasound and alpha-fetoprotein-based screening in cirrhotics have shown to be cost effective if the incidence is more than 2%, which is, in HCV post-SVR and HBV under nucleotide therapy. But in individual cases, this is also changing. So acceptance is also very important, and that's where the swan song lies, that we end up diagnosing mostly, even today, in India almost always, symptomatic advanced HCCs with portal vein thrombosis, large tumor, and ascites and all this, with a very dismal prognosis, and that's what we want to change. So what we need to do is we need to have a robust tool in hand to let us see it in a better way. The needle lies in the haystack, and we need to pick it up with a better tool in a more organized manner. How to do that? So we are entering into an era of precision HCC screening. I emphasize the word called precision HCC screening, and there are elements in that. So we are trying to develop, let me emphasize, trying to develop, and there are many tools which have been proposed. I don't want to confuse you, because I got confused when I was trying to review, and this was an excellent opportunity to update my understanding of HCC screening, and it's huge. Almost everybody is coming up with a tool which they claim to be very useful, which I think is too confusing. I think this happens when science is very energized and very, upbeat. That's good. So, and at some point we'll come out with a tool which is good. Tools are being used in combination and as well as in sequence in many screening modalities, which I'll mention. Very interestingly, in each of these, we are having risk prediction models in each of the circumstances, and cost effectiveness, culturally acceptable, and health system integrated approaches are needed. By cultural acceptance, I mean you cannot have a logistically unfeasible, very costly, and all these tools to be applied in screening, because that would be rejected by the screening modalities that are used. So the buzzword is biomarker development in HCC. So biomarker development is not a very easy task, and NIH and all the global modalities have set standards. And as you see here, you can come up with a proof of concept idea, but that had to prove through phase 5 till you have gone through all the stages. And the only biomarker that has withstood all the stages is alpha-fetoprotein till date. All the other biomarkers, like single biomarkers like osteopontin, Gallert score, L3 fraction of alpha-fetoprotein, and all that, DCP, all that we keep on discussing are in up to phase 2 or phase 3, telling us that we need to know more about each of these either alone or used in combination. And I'm going to tell you stories around that. So Gallert is one of those combinations where alpha-fetoprotein log and sequential alpha-fetoprotein is used. And that has been shown to be useful. As you see here, pickup was highest with longitudinal Gallert score detection. I'm not going into details of those. And there is another score which is called hepatocellular cancer early identification score, where also change in alpha-fetoprotein over the last year is one of the scores, along with DCP, age, platelet, and age-old other parameters. So people are trying to improve that by putting into clinical variables and alpha-fetoprotein. Very interestingly, the theory pointers group who invented FibroTest was the non-invasive tool development. They have come up with a tool named LCR1, liver cancer risk 1 and 2, which incorporates those age-old markers like apoprotein A1, haptoglobin, which was there in FibroTest, and they incorporated alpha-fetoprotein also. And then they applied this to a cohort of people, large cohort, 5,000 people, HEPTHAR, which is a French cohort, and then in people with HCV and then with HBV, telling and informing us that they are useful and with an area under curve of more than 80%, which is fairly good. So that's there. Very interestingly, enthusiastic and large things are coming up is in liquid biopsy. As you know, cancer cells are shed into circulation and in various body fluids. And people now have got modalities where they can pick up cell-free DNAs. So, your tumor components like complete tumor cells or cell-free DNAs or many components that are being picked up. And then, this was in 2020, was the proof of concept was this, phase 1 pilot of around 3 cell-free DNA modalities that a methylated fraction of the cell-free DNAs were put. And then, interestingly, they have incorporated a test called Helio liver test, which have incorporated methylated fraction of nearly 27 cell-free DNA components. And then they found that incorporating this, along with alpha-fetoprotein, DCP, and all these, age-old parameters, and if you model that, can really give you a better pickup and a good area under curve, which is promising. So many such tests are available. Very interestingly, radiological modalities are also coming up. As you know, enthusiasm is visible everywhere. And MRI is one, contrast-enhanced MRI is one of the best modalities to diagnose and one of the best modalities to confirm your diagnosis or contrast enhanced CT. Maximum enthusiasm is in MRI, but the problem of conventional MRI is long scanning time and other issues which I'm not discussing here. So they have come up with a protocol for abbreviated MRI, which include both non-contrast enhanced T1 and T2 weighted images as well as diffusion weighted images, and found that gives pretty high sensitivity and specificity. And this with a very long, short scan time, less than 10 minutes and all. So AMRI, advanced AMRI, has shown to be promised both contrast enhanced and non-contrast enhanced in screening. Interestingly, another thing that is jumping on the rock is radiomics. Radiomics is, artificial intelligence applied to quantitation of the imaging data. And this came up around 2015. And now, interestingly, in 2022, they have come up with a prediction tool, individualized prediction tool for hepatocellular cancer in hepatitis B, where they have applied artificial intelligence, machine intelligence tools based on the quantitation of radiomics data, and they found they could develop a normogram to tell you that that they are very useful in HBV detected HCC. Another modality that is coming up is radiogenomics, which is again artificial intelligence, which combines the genomic data as well as the radiomic data, and then they robustly analyze by deep learning tool and then artificial intelligence tool synthesis and all for coming to for analytical thing. And very recently in 2022, Korean and as well as Caucasian validation cohort, they have found that artificial intelligence based models based on the usual parameters like cirrhosis, age, platelets, LTST, drugs therapy and all are very useful. So, in summary, the tools, there are many tools like, you have got liquid biopsy biomarkers, you have got sequential usage of conventional biomarkers, you have got improvements in MRI, you have got improvements in artificial intelligence. But the question is, you have got a large population of, cirrhotic people. The interesting thing is, and the important thing would be, whom to use and what to use. So what to use I discussed with you. The issue is, the target stays stacked somewhere up. You have got a very pyramid-like structure with a large base. So you need to have tools fast which have risk stratification in cirrhotics. So you have got many non-invasive markers for cirrhosis right now. The traditional markers like FIB4, NFS, and all this can give you help there. But there are other tools also which I'm discussing for HCC. But then you need to apply the early detection tools, which are the liquid biopsy markers. So it's like combination of the traditional tools as well as the new tools or the MRI techniques, which can give you early detection biomarker finally for early detection and all. So the fast risk prediction came with a tool called Address HCC. This is not very old, less than 10 years old. And this was Address means each of the first lines, age, diabetes, race, etiology. This was again in a HBV infected cohort. And they found that you can develop a model to predict HCC risk in a cirrhotic. But interestingly, a very useful, and I thought this is useful, model they have come up is in all different cancer risk people, and they found that people with viral cancers, this is the large cohort analysis, have got the highest risk of HCC, and that's the Toronto HCC risk index, which incorporates again clinically useful parameters and use that in models. Now, in hepatitis B, we know many models have been used. The Westerners don't believe in the Asian models like PAGE, MPAGE, and the REACH and all these. But I think those are very useful in our setting. And this is one of the Western studies that has shown that, MPAGE, because we are treating people with hepatitis B cirrhosis right now, and MPAGE is incorporation of liver stiffness into PAGE, or REACH is something like that. And there are other changes also, DNA and all these. So there are models, many models. Let's not confuse us. REACH and PAGE are very good to be used. I think Professor Acharya would discuss those, or we have had several sessions telling us that in HBV it's useful and it's possible to predict. Now in HCC, As we are learning more post-SVR, we are saying that FIB4 and cirrhosis can be. So if you have got FIB4 more than 3.25 and a cirrhosis, your chances are highest. And it remains very high, even after this study is up to 7 years post-SVR, and people have studied up to 10 years post-SVR. So it's like that, risk remains high, even 7 years, till date we know. And you can use, your cirrhosis detection and with FIB4 tool to synchronize. And the consensus is that you should not screen, because you need to target your screening attempts to people. So it's good to screen F4 and cirrhotics post-SVR, not F3 and all. That's the ASLD guideline says. NFLD is the biggest problem. Because out here the bigger problem is people who don't have cirrhosis develop HCC. Almost 1/5 to 1/3 of the people who develop cancer in NAFL may not have cirrhosis. So you cannot really screen and detect early this subset of people. This population is very large. And with the enlarging ambit of NFLD globally, you really have got problems. I'll take 2 minutes or so. So, but at the same time, but in cirrhotics you can apply models. And here is one such model. The models is, available in the web, and it's called hccrisk.com, where again, they have incorporated the age, sex, and all these parameters, and they found that they could initially, baseline HCC predictors were added, then they were applied the models, and they found that you can differentiate that into high, medium, and low risk, and you target your attention to the high and medium risk, and leave the low risk people apart. We know that HCC in NAFL have got a genetic predisposition. So PNPLF3, TM6SF2, and all these, and HSD17B13 is one of the protective genes. So they have incorporated all these into a polygenic risk parameters, and such polygenic risk parameters tool have really proved to be useful when used in adjunct to these. So, as on today, before I conclude, I should say, how do we look forward to a future? So we need to refine our screening strategy. As for the population applicable thing, even today, our strategy is ultrasound plus alpha-fetoprotein application, but it's going to change very soon. So we need to refine by risk stratification. Once we have got all those GALAD, LCR1 is a patented one, GALAD is a non-patented one, we can use those, along with artificial intelligence techniques which are also going to come. Now we can divide that into a moderate or high HCC risk, and then we can subject that to AMRI, or if available, conventional MRI with more targeted early detection techniques for early detection and screening. But if the risk is low, then we can go forward with ultrasound screening and other techniques. But importantly, for any policy to be implemented, it has to be integrated into the system. That needs physicians' awareness, physicians' understanding, and as we all know, that people with cirrhosis are really not keen to undergo periodic screening, at least in India. So we need to keep on telling this more often, that every cirrhotic have got a more propensity and use the risk, and so role of education is very high. And so the buzzword is that HCC really happens at a higher frequency in cirrhotics, and we should use more often the risk models, use the new biomarkers that are coming, and try to improve our early detection for improving enriching the people whom we can offer the best modalities of therapy. Thank you all for your patient hearing.
Before we move on to take up audience questions, I will invite. Thank you, sir, for extensively covering the topic. So before we take up audience questions, I would like to invite our expert panelist opinion. Sir has discussed many markers. Most of the markers are likely mostly in the research setting, the fluidics, microfluidics, CTC. However, the not so old markers, AFL3, GCP3, and DCP, sir, I would like to know what is your standard of practice and how much do you incorporate in your practice? Also about the risk stratification discussed, do we stratify our patients into high risk, ultra high risk, mild or moderate risk, or we have a blanket screening policy for all patients? So comments.
Thank you. So thank you for the insightful lecture, sir. It's a very interesting talk. The problem with our centers or whatever we are doing in India is we are very resource limited. I think that is the biggest challenge that we face in any screening protocol, because patients tend to not follow the screening protocol, and again, if they follow it, they tend to drop out later on. And even with all the tests available, I think AFP remains the most cost effective for our patients. And with all the DCP and PIVCA and everything available, again, cost is a factor and availability is also a big factor. So till now, at least in our practice, we are using USG as well as AFP. I mean, Apasal is still recommending and we are still using it. And unfortunately, like Sir said, we are still diagnosing patients too late. When they have already become portal vein thrombosis and tumors are becoming 5-6 centimeters, then we are diagnosing it. So any other
I think, Abhijit, as usual, so it's every time we learn from you like anything. See, I think 2-3 important issues. Barrier to screening is very important throughout the world. And country like ours, barriers to screening has to be considered. You can't screen at least maybe 10-20% because of not patient mistakes. We don't know. We doctors have to take an oath in this hall that we have responsibility for this patient to come back to us, go to a radiologist, go to oncologist, and get them checked up. That is one important issue. I always feel what we are doing ourselves in this country. So barrier to screening is one. Second is, I was thinking that, as Dr. Usha is also sitting here, US LIRADS, is it or has it changed also? That might be also very helpful, that after you have a LIRADS applying to US, ultrasonography, I think has very important. The other thing, Abhijit, that I didn't have a time to talk on secondary screening. You have treated HCC patient. When do you want to take them back? In 6 weeks, 3 months? You do a AI, you do a microRNA, you do a alpha beta protein, you do a FIFCA. What do you want to do? In our setting at least, Abhijit.
So I really did not cover, I wanted to cover the people with cirrhosis as applied to mainly population and people with that. So that's a different topic, because most of these modalities, if you want to screen post-therapy people, then and the people are hooked to the system, then your best modality for screening would be cross-sectional imaging techniques.
Yeah. Yes.
Because all the biomarkers are still very non-specific and lack sensitivity to give you ideas. And you have got a underlying cirrhotic liver.
Sir, AFP along with ultrasound takes it to 65%, as sir said. But sir, abbreviated MRI, sir, would be is at 50% of the price of original MRI. Yes. And that's not an enhanced MRI. So I think that modality, although resource setting, but price-wise, it will be much cheaper than combined above two tests.
Anybody else? Yeah. Professor Chaudhary, can I ask a question? Sir, as you have rightly pointed out that with universal vaccination and rise of diabetes, I think in decades or so we'll be seeing that hepatitis B would be relegated at the lower end, and the NFLD will become the higher risk factor for HCC. And you have said, so do you think since the cirrhosis, you have also pointed out that cirrhosis may not be the predictor for HCC, because many of the people may develop HCC without having cirrhosis. Do you think circulating tumor cells with the cost of coming down will be a relatively specific and sensitive screening tool?
Problem of cfDNA would be, they are still not that robust tool to tell you that, hey, you are right on target. The question is not of sensitivity also, the diagnostic accuracy, the negative predictive value. So if once it passes through, and you cannot say biomarker development would have to go through those rigorous processes. So the cost is not the only concern. Their robustness of diagnostic accuracy is going to be a concern. That obviously that will be preferred at some point of time.
Because as an oncologist, we are seeing liquid biopsy as actually becoming a tool which has actually overcome intratumoral heterogeneity. With and minimal residual disease.
I'm concerned that's not in NFLD right now. NFLD is too heterogeneous and too ill understood a disease even today to give us in very near future a tool to develop NFLD associated HCC by liquid biopsy. That's my only concern. Each cancer in each location has got a different biology. So in NFLD HCC we don't understand the disease. We don't understand NFLD, we don't understand NFLD HCC as of now. That's my only concern. We need to know it more.
So India being diabetes capital of world, and the diabetes is an important risk factor for HCC. So how do we increase the awareness that diabetes is a risk factor? People know about hepatitis B, alcohol, but they are very, unaware about the general physicians. They are more worried, they are rightly worried about cardiovascular diseases outcome of the diabetes. But hardly anyone is worried about liver disease, NFLD occurring in these patients, and then following that with so your comments on this.
No, Ashish, I fully agree with your concern, but I was just looking, trying to think about your proposition from a larger policy perspective. You know, diabetics are really not concerned about their glycemic control at all. That's the large, if you go to the diabetic world and see how many people are following up for glycemic control with the diabetologist, I'm pretty sure you're not going to get more than 10% or 20%. And that's what I gather from, our diabetologist friend. So, the only issue is, okay, you are going to have a richer harvest of HCC if you keep on screening your diabetic population, no doubt in that. But the problem is, will that be culturally acceptable? Will that be system acceptable? Will that not end up losing more of your diabetics from the system acceptance? They may get lost, hey, I can develop a cancer, let's not go to a doctor. Denial. We all knew that people with COVID were not testing themselves. You know, once they knew of COVID, they were not testing themselves. So not trying to know about a disease. So system integration and application, implementation of a modality is really not going to be easy. It's good proposition. From our, vision, we think that this is going to be useful. But when you apply that to a larger ambit, I'm not pretty sure that, telling diabetics that you can develop a cancer and you should get screening for cancer, we can say that you can develop a liver disease is going to be useful. Yes, Professor Acharya has got a comment.
You see, what Dr. Kingsud Das and you told is very important. All your efforts is to identify early disease. Now, you know the risk factor. So, Vijay pointed out first point, risk stratifications. What is risk stratification? Particularly as the chronic liver disease is more advanced, you have more cancer, and there are multiple risks associated to increase this cancer, which is well known today, like obesity, not only diabetes, obesity, advanced age, male sex, already known. If you stratify the risk, first thing, you can risk stratify. And as a clinician job, second, you are detecting early cancer. Early cancer, you have to screen. Screening by definition is a tool which can be repeatedly used, easily accessible, and will be cost effective. Means the cost should be low to detect more number of cancer what is incidence. So the screening test is very important. Till that, as Avijit pointed out, no screening test, including Dr. Panda, your liquid biopsy, there are 7 panels of methylated DNA which has been compared with alpha-beta protein, combinations of various parameters, and tell me a single cancer which is liquid biopsy has used as a screening to detect early cancer providing curative. So these are in pipe. What you have ultrasound and alpha-beta. Nothing has matched. Now we have Ballard score, we have Gallard score, we have Gallada score, we have Toronto score, we have multiple scores, right? But ultrasound alpha-beta protein, mat. And you told about the modeling. Third thing, risk stratification, screening. Third thing is modeling. Modeling in ultrasound and alpha-beta protein, what you have indirectly stored, has a very high sensitivity rate on one basic factor, that is adherence. Simple. You see, we are discussing all the parameters, but the most important parameter is adherence. Even though only ultrasound is 40% sensitivity to detect cancer, if you have 80% adherence, the detection rate increases by 3-fold. It becomes 70%. So for our country, these are very important. As a practical knowledge, as Inasl proposing, to focus that this is can be practiced, can be applied, can be informed, while obviously artificial intelligence not only low cancer, in every cancer in every disease, even in sales, even in marketing, even in industry, is going to revolutionize, even in endoscopy. I think Professor Mahesh Gonka gave a brilliant talk on artificial intelligence, right, as the president of Indian Society of Gastrology. So that is going to revolutionize another tool everywhere we'll use. But what we will do now, that's the problem. I think that's what I think. As a clinician, this is what I have seen. And most important thing, Dr. Goenka is the most important person, Usha Goenka. She should have 5 people under her who will be only looking at cirrhotic liver, chronic B, fatty liver disease. No other disease. You will pick it up. We have not done that randomized trial. We can do it here. These are very practical things because any of these things to come, it will take years to be practiced. It's fine for us to discuss. We should know. But to practice and implement, it will be very difficult. I think these are very important practical clinical.
Thank you, sir.
Thank you.
Thank you.
Check, check. Okay. Hello, check.
After this scintillating discussion about screening and early diagnosis of HCC, now we move on to the next session. If once we have diagnosed the HCC, how do we stage this? So for this, I would like to invite our moderator, Dr. Mahesh Goenka, who needs no introduction. And I want to congratulate him for the recent award he got for ASG. So Dr. Mahesh Goenka would take over. And I would also like to invite the chairperson, Dr. Jaya Ghosh Chatterjee, Dr. Saptarishi Vishnu, and Dr. Siva Shankar Gangi Reddy to come to the dais and begin the proceeding. Dr. Goenka.
While the chairpersons are joining, let me congratulate Inasl for this initiative. And it's my pleasure to moderate a session by our esteemed teacher, Professor Subrata Acharya. Dr. Subrata Acharya has been the head of the Department of All India Institute of Medical Sciences, the most premium institute, and has possibly the largest experience in India on HCC. I am aware of the data which he has published extensively. After All India Institute's job as a HOD, he has been working as a pro-chancellor of KITS University in Bhubaneswar and is the executive director of gastroenterology and hepatology in Fortis Hospital, Delhi. Sir.
Well, thank you, Dr. Goenka. And when Mahesh is sitting, I'm always a little have trepidation because of his inputs. But thank you. And now you have realized that despite our efforts of screening, we just discuss about screening and early detection of any cancer. But problem is, world over, we have failed it. Second thing is whenever screening and detecting early cancer, combining treatment is mandatory. Without that, screening doesn't improve survival. Just to screen means nothing. And that's a huge gap in this country. And that's the result. All cancer presents to you as a cross-sectional fashion at different tumor burden, right, with different types of spread, with different constitutional symptoms, and also associated other morbidity risk factor. And the therapy in the meantime, over a period of every cancer, has improved because of knowledge in this cellular level and understanding the molecular crosstalk between various cancer cells, their development and their progress, and intervention thereof. And therefore today, staging of a cancer is another aspect while dealing with such patients. And without fail, everybody know that when you to stage a cancer, we estimate the burden of the cancer so that you can predict the prognosis and possible response to therapy which is available, as well as you homogenize them. That's why you do stage. You group them. You group them to provide prognosis, a particular therapy, possibly there to identify the effectivity as well as tolerability. Right? Besides many other factors. Hepatocellular cancer is a different ballgame, as Abhijit has already pointed out. It is not only the cancer at its burden, or it is spread, or it is invasion, or if it's biology, which is very important, it's very variable. Some tumors grow slowly, well differentiated. Some tumors grow rapidly, they are poorly differentiated. Some tumors, you will see liver cancer growing over a long period of time. Some will have rapidly metastasis. Tumor biology and tumor biological marker are also very important. But cancer mostly tilted, barring fatty liver disease, which is the Achilles heel, occurs mostly in cirrhotics. Cirrhotic is another disease. It has a sequelae, right, like varices, like ascites, like edema, like low platelets, symptomatic, asymptomatic, multiple variables, right? It is different etiology. The etiology influences also the tumor and control of etiology. It has a recurrence potential, that is all biological aggressiveness, so many variables, and the survival probability is different. And therefore, we need to homogenize them further. It's more important. And here staging is much more difficult than any other solid tumors, because here we have to think about the underlying liver disease, their status, their etiology, and their sequelae as well. However, and over a period of time, if you see, I have listed the treatment as Dr. Ashish has pointed out. Now, HCC, as I told from the beginning, can be cured today. You can replace the cirrhosis and liver tumor together, right, with a transplant. Even if you can resect liver cancer with a long 5-year survival, you can ablate the cancer with a long 5 years. They are curative options. But when you can cure, when the tumor burden is small, the liver is good, the fellow is well, and he can tolerate it. You can do it. Those patients are small. But you see advanced stage cancer. You can bring them to this tumor stage. That's the advantage. What Ashish is telling, down staging. How do you down staging of this advanced cancer? To subject them to liver resection and transplant? Because the previously non-available therapy for advanced cancer now has advanced. Now you have heard about transarterial chemoembolization since long. Now more effective treatment for intermediate or advanced cancer available. And as this was stated, I did not discuss detail, they will be discussed subsequently, like drug-eluting bead or selective intraarterial radiotherapy, like TARE, right? Outside focused radiotherapy, SBRT stereotactic body radiotherapy, with a large amount of radiation to a focused area. Now your portal vein thrombosis was not being treated. You can knock it off inside the vessel. Until date, the latest BCLC doesn't allow that it should be treated. They can be treated, can be resected, and they're being transplanted by Prasad, sitting here, right? And systemic therapy, Dr. Panda will say, huge explosion. Therefore, they told first line, second line, third line. The most advantageous thing is people are combining them now. And combining, reducing the tumor burden. So not curative tumors being curative. And that is why the staging has assumed more importance, how to put this therapies to increase the ambit of therapy to cure more people or provide more effective intermediate palliation. That's the purpose of staging. And as I told, that I've given just 4 important reasons for staging. I need not go into the details. I've explained you. Indian National Association of Study of Liver in 2023, which will be published, now collated multidisciplinary team. They're oncologists, they're interventional radiotherapists, they're radiation oncologists, they're surgeons, they're transplant surgeons, the hepatologist, the gastroenterologist, everybody combined. And for 2 days discussion, I think, continuous 48 hours, every aspect was discussed, particularly for intermediate and advanced HCC, not for early HCC. Early HCC is fairly same all over. But for intermediate and advanced HCC, the whole treatment has exploded. And effort is to increase the ambit. what I have written last, effort has been made to further subcategories and homogenize stages to increase the ambit of therapy to supposedly local advanced disease, which is not curable earlier, to make it curable. And that is the advancement of all the staging today, right? Now, there are many staging systems in ages. I think those staging systems are outdated. Like GIS score, CLIP score, right? All these Italian staging score, they are outdated. They are old. I will give you certain old outdated score. That as we discuss, all staging must not only give you about the tumor burden or invasion or spread, it should also give you liver status, right, prognostication, and the present treatment allocation, which is advanced. How can you provide to the stages? You have to subgroup them so that you can increase the ambit of therapy. That is why the staging has changed. And staging must be contemporary, depending upon the advances knowledge, so that you can pass on the effective therapy. That's the problem if you follow old staging system. That's why BCLC published this. It's not, it looks very complicated. It's not. You see, we have discussed cirrhosis as early, intermediate, or advanced, or terminal. Early is the liver function test is good. You can cure it. You can resect it, transplant it. If resection and transplant is not possible because of certain reasons, resection is criteria. I will discuss that. Or transplant is not feasible, then you can ablate it. And they are called as BCLC-A. Depending upon the tumor burden, they have divided single tumor, right? BCLC-0, sorry, is less than single tumor, very small tumor. And you can transplant it or ablate it. Even ablation gives him good result. Accordingly, early stage, intermediate stage, if you see, and advanced stage. Mark it, one thing. All these stages in American or European classification as preserved liver functions, good liver function. They are good patient, performance status is 0. They are working throughout the day, right? They are not taking rest. And they are treatable patients according to the stage. They have subdivided them into that further, and they have not changed the early stage or very early stage. That is small number of tumor, less than 3, number is 3. That is BCLC-A, or BCLC-0 is single tumor less than 2. A has been further subdivided into two groups depending upon number, but the size is less. They are Milan's criteria which you discussed for the transplant. But what they have done, they have divided this intermediate stage into 3 further stages. Previously, all BCLC-B were considered portal vein free, no extrahepatic has spread, but the tumor burden is more, that is more than 3 tumor, more than 3 in number, which cannot be subjected to ablation or resection. That was a concept earlier, which is no more true. It has changed. That's why they have grouped into 3 groups, because now it has been seen that you can transplant patient with a larger tumor burden. If you ask Prasad, he transplanted even with 5, 6, if the portal vein is free and it is not spread beyond the right liver. So they divide into 3, B1, which is, right, you can go extended liver transplant criteria, that which is the conventionally UCSF, University California, San Francisco criteria, which they say, okay, increase the tumor size a bit, little. More than 3 number or more than 3 centimeter, you can increase it, right, to total 4.5 centimeter. 1 tumor more than 6.5 centimeter, which was earlier largest tumor was 0.5 centimeter. So they showed the results are similar if you have UCSF criteria. Now people also work beyond that, and you can downstage them and subject them to transplant. They included. They found another group which is a large tumor burden, which doesn't fit into UCSF criteria, which cannot be transplanted or cannot be downstage easily, can be subjected to conventional treatment, TAS. But here in this group, TARE has been, or combining multimodality treatment is also effective, which not has been very much taken into account. And the third variety in BCLCB, they told, there is a diffuse tumor, where vessels are free, but they don't respond well to transarterial therapy. They say you go to systemic therapy. But they didn't mention about the radiation therapy, which is more effective in that. So this therapy, which is published staging in 2022, even also not used all the published literature about further advancement, which INSL has tried to do, isn't it? That is what you have done. And I will not discuss about chemotherapy first, second, third. I think Dr. Panda is going to discuss. So what is the improvement over previous BCLC? I didn't mention about the liver function. If you see, the liver function say good liver function. Which is good liver function? Conventionally, child's CTP less than A6. They divided into further. CTPA, which is called ALB score. I'll discuss ALB score. And they found ALB score further predicts the outcome of this treatment, right? And they influence also aggressive therapy like radiation or TAS, right? And even within child say, there is a variable outcome. They categorize BCLCB, as I told you. And third thing they described, treatment stage migration, which was not there earlier. That means if the patient getting treatment at one stage as that has been allocated has not shown response, that is untreated progression, or has shown increase in size, they define 20%, right, or occurrence of another nodule, they call it is progression, should go to the next higher treatment. That is the addition. And downstaging, as well as I told in the B group, which a portal vein is free, is an option to provide curative or resection or a transplant or ablation. And systemic therapy for all other, right, advanced cancers like B3 or the BCLC group where portal vein is involved. Again, they have taken all portal vein invasion into one group. But you will see intrahepatic portal vein invasion and extrahepatic portal vein invasion can be dealt differently. Intrahepatic portal vein invasion has been further classified depending upon the order of portal vein invasion. You have a major portal vein, left and right, then the left divide further, then that also further divide. So beyond second order, if it is blocked, that is a small block. That Japanese called BP1. The second order, Japanese called it is BP2. The main branch, it is BP3, main right or left hepatic vein. The main vessel, it is BP4. Now BP1 to BP3 can be treated today, can be resected, can be subjected to SBRT, can be subjected to tear, and can be made free, and can be offered transplant. So the downstaging has become easy. These are the new things that has come, which have been included in the stages. So this is this. So this is what I told ALB score. I'll show you, and these are the three things they have decided. And now there are many studies which I am showing. ALB is this. It is a logarithmic score which you can calculate in a calculator in your smartphone, which is available, and can be graded into two depending upon number like MELD score. And if you see, even in A, see the difference in 5-year survival in all resection, transplantation, ablation. It is, in ALB1, it is about 90%, 5-year survival. And in ALB2, it is about, at best, 75% variable. And there is increased recurrent fair survival. So this is the finer addition that has happened, which is important, I think. We have not used that. I think we should tell that because this is available. And if you see the ALB score, intermediate and advanced cancer also made the same difference. So better the liver function, irrespective of the tumor advantage, tolerability is better, the ambit of patient number is better, and hence the result is better. So that is what is ALB score. That's why important. And treatment stage migration, I told about it. And when there is a treatment stage migration, there are now advanced therapy about which Dr. Panda will discuss. I will not waste time. But I pointed out the flaws. If you see the intermediate stage where portal vein is free, even though they are defined into 3 groups, they didn't told anything about resection. I told VP1 can be bed free, VP2 we can be bed free, VP3, and in our country you cannot do transplant. We can resect, and ablation is not also available. Resection is available. And you can combine all this therapy. That was not mentioned even in the BCLC. You can combine today. We can combine, say, tear with ablation, microwave. Tear with microwave, TAS with microwave has shown very good results, right? Even with the advanced cancer, even in Dow's staging. So all these things has not been included. Third thing, any patients with a terminal stage T, for example, child C patient, they say it is terminal stage. A child C with a single tumor or 3 tumor within Milan's criteria can be transplantable, right? And can be cured, which was ignored, which we have included. And resection criteria. I think Prashant will discuss. Are you discussing about resection criteria? So I will not tell about it. It's a very common figure. Essentially good liver, less amount of resection is good. Number of segments and technical feasibility. And therefore, you should. But there are many factors now, and I think Prashant will agree. Besides, this is ESL, right? That is based on portal hypertension extent and liver reserve and the location of the tumor, which are variable affect resect. Now, there are many studies on functional liver volume, right, by ICG, even simple fibroscan values, which you can also predict, right. And also, I will point out, I have just mentioned it, I will not discuss on it. There are many other variables which has come in for assessing the success of resection. And there are many ways to improve the residual liver volume following the resection, right? Which our surgeons are also using it, and people are advanced tumor can be treated using this resection technique. So resection technique has also advanced. Treatment to downstem has advanced. Therefore, this is very important. And resection, this is Hong Kong classification, which used resection. In advanced criteria, I will not go into the details because of timing, but I can discuss in detail. And if you see, they have divided in stage 1, stage 2, stage 3, and stage. You see, resection is everywhere. And in fact, they resected all these tumors, including portal vein invasion, inside the liver, including large tumors. They have decided early, intermediate, depending on the tumor size, tumor number, and vascular invasion. And they showed that, in fact, the survival using HKLC criteria, when similar patient with BCLC criteria, it's much better because resection provided them benefit. So you see resection, how important it is. That is the purpose of showing this. APSL, unfortunately, HKLC could not use TAR or SBRT because they were not available at that time. It was done in 1998 to 2005 in more than 4,000 patients. At that time, it was not available. Resection was available. That's why it was used. Now, APSL was a recent therapy. They also used similar thing. They didn't change, right? They just they decided, let us focus on the liver. It is inside the liver, and there is no portal vascular invasion. They are different. It is outside the liver cancer, right, or major portal vein obstruction. Clear from the beginning. If it is inside the liver, if the tumor burden is small, then you can do RFA. If a tumor burden is large, depending upon the liver function, you can ablate or even resect, right? Or little liver function bad, these are within Milan's or UCSF, you can transplant. If a tumor burden is very large, right, you can downstage them with TAR, SBRT and subject them to curative therapy. But if liver function is bad, it's very difficult to treat, tumor burden is more. That's what they suggested. So this is what how is changing. So we have combined all these things. See, for early, that is 0 to A, right? That is, BCLC 0 is less than 2 centimeter. BCLC A we divided into 2. Single tumor, more than 2 tumor, but less than 3. Size is 3 centimeter. Treatment is curative, as I discussed, because they are small tumor and their liver function test is very good. That's CTPA. We have not used ALB. We may use ALB depending upon our data later on, right? BCLCB, we have divided into B1, B2, B3. But what we have done in BCLCB, we have increased the CTP score to up to 8, because sizable number of patients with a low albumin or mild ascites will have 2-2 score, and CTP almost reaches 8. You can correct them. They tolerate, and they are resected. So we have increased to this. And if you see BCLC, performance status 0, we didn't say. Performance status 1 means he is able to do all his work. He cannot do the strenuous exercise. That's all. So you are excluding them for curative treatment. We didn't, right? That's what we have done. And we tried to, as I suggested, multiple modalities. The effort is to cure them. Previously, remember, BCLCB TAS. The effort is to provide multiple therapy, which has been discussed in the guideline in details, and try to cure or provide at least more effective palliation using all these therapies. If necessary, multiple. That is what we have done. And advanced BCLCC, the intrahepatic portal venous invasion, right? We have also tried to use multiple therapies, subject them to possible curative or resection. That's what we have suggested. So this is what I have details of the present, which will be published. I don't want to go into the details because I have discussed this. So this is the Inasl criteria. What we have done, I will go to the next. We have divided into 4 liver function tests. It's a very good liver, right? Where almost A. We can further do it by LB1, LB2. An intermediate liver, where the functional status is good. As I told, PST is less than 1. Intermediate liver is CTP up to 8. Also, if the functional status is more than 1, with the intermediate liver function, we have, this is our BCLCC, this is our BCLCB, and bad liver function. So in early liver function, as I discussed, the treatment remains same. In intermediate liver status, I have already suggested that even beyond UCSF criteria, we can suggest downstaging using multimodality treatment for possibility of a transplantation. And with well-defined nodule switches previously for TAS, we have used tears, or if there is BP1, BP2, we have used SBRT as I discussed. And diffuse TAS is not effective. We have suggested radioembolization because it has been shown in randomized trial that there are 2 randomized trials which have shown the effectiveness. These are the changes which we have brought in, which has included all the latest changes. And also advanced stage. Inside intravascular lesions has not been excluded at all. They can be cured by SBRT or even tear and can be treated, right, effectively in select cases. If they fail, then you go to systemic therapy. This is the advances we have got. And in the terminal stage, suppose child C, if there are within transplant criteria, you can transplant. What I have not included in the future, and before we submit, I think I'll request assess, we have affordability problems in liver transplant. You are doing life-related liver transplant. Out of 100 eligible transplant, only 10 are able to do it. So if it is not possible or donor is not available, we should put in a bar here for resection, because resection is better than ablation as far as recurrence is concerned. That is one thing. And multimodality we have not used as an alternative to transplant. If it is not possible, you can use multimodality treatment. And now there is an adjuvant therapy. Around some studies shows sequential therapy also. There are evidences that I will add here further. So in general, I will say advanced local therapy to take care of intrahepatic vascular lesion and more tumor burden. That is the addition we have given. Systemic chemotherapy, molecular target therapy, anti-angiogenic molecule, immunotherapy in combination, and sequential therapy, which is the important thing in advanced and intermediate HCC. If they fail the previous suggestion, I think we should include. Using the therapeutic potential of HCC studying, they are being subcategorized to deliver more personalized treatment. We have been calling about personalized treatment. What is this? This is personalized treatment. Identify the tumors, identify the invasion, identify the spread, use the multiple modality, give them personalized treatment to offer them more curative options.
So we'll have to wind up sometime.
However, this treatment can be delivered to person with larger number tumor burden, that is the stage, even with vascular invasion, with good liver, good performance status, and without extrahepatic spread. They are the basic criteria. And another thing is tumor biology. Thank you. I've tried to explain. There's so many advances which has been put into the stage. It is difficult, it needs time, but that is the basic concept. Thank you.
Thank you, sir. Since we have crossed the time, we'll have only time for a couple of questions. Any comments from the chairpersons? Sir, before there is a question, is there a place for alpha-fetoprotein being included in the staging system?
I told you about tumor
some
biology.
of the Japanese classification to include.
Yeah.
And why Inasl, in spite of the recent knowledge of LB score being more important than CTP, has not included LB and has continued with CTP score only?
Well, because we have, you see, LB score also has to be popularized. It has to be practical practice guideline for most people. It is easy. It has been practiced more often. And I agree, I discussed why LB score should be used. And it is for experts like you to further use it. And another question was alpha-fetoprotein.
You said tumor burden, which possibly?
No, alpha-fetoprotein is a marker for biological aggressiveness of the tumor.
Some of the Japanese classification or staging has included alpha-fetoprotein as a part of the stage.
Not only Japanese, multiple, particularly transplant people, they have used alpha-fetoprotein as an important marker to select patient transplant or subject patient to transplant, because alpha-fetoprotein more than 100, some say less, is supposed to be associated with low recurrence rate. Alpha-fetoprotein, the size of the tumor, the vascular invasion, after downstaging the waiting time, and PET-CT, and histology of poorly differentiated HCC are 6 markers for biological aggressiveness. Easy is alpha-fetoprotein. Very high alpha-fetoprotein is mostly poorly differentiated HCC, likely to have more vascular invasion and like to have more recurrence. Therefore, alpha-fetoprotein is used by a criteria for transplant when you are downstaging, and one of the many endpoints use alpha-fetoprotein. At least there are 20 criteria. Surgeons published all these things.
Yeah, so excellent talk. So I have a couple of questions. One is, what are your comments about a single lesion more than 10 centimeters, where you cannot use local therapy, where you're expecting a liver failure in them if you're using a local therapy?
Well, people you can combine, but if you use a tear as is suggested by BCLC, transarterial radioembolization, for large tumors, more than 5 centimeters, single lesion, is very effective. You can use also multimodality. Even in your setup, you can use a lipoidal test. And lipoidal is a good agent to mark the amount of covering of the tumor, right? And you will find some tissues are left. You can microwave, ablate them. You want a complete tumor ablation.
I'm sure there will be more discussion on this in the subsequent talks.
They are individual patients. You can use all these techniques to treat them. I think most of the liver cancer patients, if their liver function test is good, right, if up to CTP8 can be treated today.
Dr. Jaya, you want to make any comment? Dr. Vishnu?
Yes, surgeons use TNM staging, but TNM staging probably doesn't, this is a tumor node metastasis. It doesn't use the liver status, which is a very important determinant in patients with liver cancer. Therefore, we don't use much often TNF staging, right? More often you use Right, but TNM staging, many surgeons and many patients also describe TNM staging. But I personally think TNM staging is not valid for HCC.
I think every good thing has to come to an end. So we would finish with this particular session and would hand over for the next session. Thank you, sir.
So after discussing staging, now we move on to next topic, that is liver transplantation. There's been so many advances in liver transplantations, especially regarding downstaging and various other, post-transplant management of these patients. So for this session, I would like to invite our moderator, Dr. Kinsuk Das, to come over stage. And also, I would like to invite our chairpersons, Dr. Debashish Banerjee, Dr. Saubik Das, and Dr. Manoj Kumar Agrawal. Dr. Kinsuk Das, please invite the speaker and begin the session.
Yeah, thank you, Dr. Ashish. This is really a fantastic meeting. In fact, I will, before I ask Dr. Prashant to start the ball rolling, see what Dr. Subrata Acharya has said, very important issue. The Milan was morphological. You forget Milan now. 1980s, who did liver transplant for HCC, patient died. In 1990s, who got Milan, you have morphology. Morphology is not going to help in 2023. You need biology. So we have advanced from morphology to biology. You need surrogates, you need biomarkers. And you don't bother about TTV 115 centimeter cubes. So that will be, I think, Prashant will tell all those things. You need to look at the HALT HCC, you look at to models, you will look at to so many scores, and you really downstage them, locorenal therapy and others, downstage them and really do a resection in these patients, transplant in these patients and give them a life which we are not able to give over the last 40 years. So with these small things, I think I am really proud or privileged to call Dr. Prashant Vangi, who has done his masters in hepatopancreatobiliary surgery from the France University, that is the Henry Bismuth Hepatobiliary Institute, and then his European Inter-University Diploma in Hepatopancreatobiliary Oncology. He is presently the Associate Director and Senior Liver Transplant Hepatobiliary Surgeon, Institute of Liver Transplant and Regenerative Medicine of Medanta Group of Hospitals. Dr. Prashant, please.
Thank you, sir, for that quite very kind introduction. And first of all, thanks to Inasl for making a part of this. I see I am probably the only surgeon today in the entire audience, but I've always been associated with Inasl and it's always a pleasure. And I think this is an excellent initiative, going around the country trying to spread awareness on HCC, which is absolutely essential today. I was given a topic by Dr. Ashish, all you need to know about liver transplantation for HCC, when, whom and how. And I think we spend years to know when, whom and how. To do it in 20 minutes is not easy, but I'm going to try my best. So it's not that simple. And the question mainly is how to achieve best outcomes. What I'm going to try to do today is rather to put in some concepts and some thoughts rather than giving you data which you can read everywhere. To me, when means you choose the right strategy, ablation versus resection versus transplant. How, to me, means selection criteria, how far can we go in HCC to transplant them, and whom, according to me, is who are the best candidates for transplant. Let me go to the first one, and this is not a big debate or a big issue. If you have a very early stage HCC, you have an early stage HCC, you have all those options. Liver transplantation gives you the best answer. These are the validated criteria. I'm very happy that a hepatologist and a gastroenterologist, Dr. Das, said that it is no longer about Milan criteria. It's no longer about UCSF criteria. It is about tumor biology, and I'm going to try to tell you why. This was the Puri 2 recommendations of Inasl, and again, Here if you see, we did go to very early stage and early stage in 2018-19, but we added this stage D1, where even with advanced liver failure, if you have a tumor which is within transplant criteria, we should transplant them, and this was not there in BCLC at that point of time. I want to put in a word as a surgeon for resection. We also said that the feasibility of liver resection should be assessed in patients with no clinically significant portal hypertension with potentially R0 resectable tumors. That means you resect the tumor without leaving anything behind, especially in unilobar tumors with moderate residual liver function and volume reserve. So do not forget about resection in patients even with BCLC-B. I'm coming to selection criteria. How far can we go? Before I go to how, I should try to say, why should you do transplant in multifocal HCC? We used to talk about single tumor, 5 centimeter in size in the Milan criteria, single tumor 6.5, and now we are talking about 10 or 12 tumors, none more than 1 centimeter. And we are talking about Japanese criteria, I think someone alluded to it, 550, 500. So, why should we transplant patients with multifocal HCC? Are they all going to recur back? And that's why you should not transplant them? This comes from basics. HCC by nature is a multicentric disease. You may see one tumor, you may see 2 tumors, actually there are hundreds of them within that liver. Because the root cause of HCC itself is the diseased liver. The diseased liver gives rise to the HCC. You treat one today in the right lobe, you'll have 10 tomorrow coming in the left lobe. And liver transplant has the potential to cure both the things, the underlying cirrhosis, which itself is the ground or environment to develop HCC, and also the HCC per se, and you can achieve the best R0 resection with a transplant because you're going to take out the entire liver. So I'll come to the selection criteria now. I said accepted, best outcomes probably, but in real life, you and me, do we see those early HCC? And we do not. 90%, 80% of the patients who come to us are coming with multifocal HCC, or they come with a large HCC with vascular involvement. What does BCLC say for them? TACE, sorafenib, palliative, 50%, 3-year survival of 10 to 40%. Complete no for resection and transplantation. And if we were to do this, we are going to lose all of those patients. So is there anything that we could do at least for a few of these patients with whom I define as locally advanced HCC, which are stage B, stage C, with no extra hepatic disease to improve their survival? So which are the patients we are looking at? We are looking at this intermediate stage, and we are looking at the advanced stage patients. There are several published expanded criteria in both the DDLT as well as in the LDLT setting, which go beyond Milan, they go beyond UCSF criteria. And still, if you see in that right hand lower corner there, they are still achieving more than 70% 5-year survival. This is LDLT, and the maximum expansion has happened in the LDLT setting in the East, because we are not having the DDLT organs, and therefore, because of the need of trying to treat these patients, we started with LDLT in these patients, and today we have moved away from size and number. The main impetus today is there should be no extra hepatic disease, there should be no gross vascular invasion, irrespective of the tumor number and size, but what is most important is you need to consider tumor biology. If you consider tumor biology, and if you have good tumor biology, you are going to have more patients who are transplantable and better outcomes. So if you look at all these criteria, you will see what is common to these criteria is almost all of them are incorporating tumor biology, because today tumor biology is the king, and it's not just the size and the numbers. This is the ILTS consensus conference, Transplant Oncology. We published this last year in Transplantation. I was the first co-author with Neil Mehta from UCSF in this paper. And I want to point out a few things that we said in this paper and this consensus conference, which ultimately led to the change in BCLC. We said that selection criteria should consider tumor biology, tumor size and number, transplant benefit, I'll talk about this a little later, organ availability, wait list composition and allocation priorities. And gone are the days of a single criterion. We are now talking about composite criteria. And these composite criteria, they include surrogates of tumor biology and response to neoadjuvant treatments, which we call downstaging. And these are likely to replace all the conventional morphological criteria. We also said that selection criteria for LDLT may be different as compared to DDLT. DDLT is a resource for everyone. We are using organs from cadaver donors or disease donors, which itself are few, and we may compromise other patients who are on the list, but LDLT, a patient has his own donor. So you can expand the criteria, of course not expanded beyond the limit. Again, I'm going to stress on that a little later on. And that's why we said that the minimum acceptable survival of the recipient should be at least 60% at 5 years after expansion of that criteria. Otherwise, you should not expand the criteria because it will not respect the equipoise concept. So I'm just going to give you an example of tumor biology in expanded criteria. And I've always said this before, I like to use Indian data. India today has one of the largest data, which probably we are not publishing. We are the number 2 country in the world doing the number of transplants in a year, and we are not publishing our data. This is our data. We published this last year in liver transplantation in 2021, where the title itself was Incorporating Tumor Biology to Predict HCC Recurrence in Patients Undergoing LDLT Using Expanded Selection Criteria. This is our current selection criteria at Medanta. We've been following it up for more than 15 years now, and we are not going according to tumor number and size, but there should be no extrahepatic disease, there should be no major vascular invasion. So this is the data we actually published. So 405 patients of HCC. Till date, we have 645 patients of HCC who have undergone living donor liver transplant. You look at that cohort and you will see that 51% of them were outside Milan, 49% of them were outside UCSF, and we still had a 5-year survival of 64%, a 10-year survival of 55% in these patients after transplant, recurrence-free survival of 70% at 5 years. We looked at the prognostic factors for recurrence. They were alpha-fetoprotein more than 100, beyond UCSF criteria, and FDG18 PET avidity. Based on this, we developed a prognostic model, and we said that there are 3 groups, a low-risk group, a moderate-risk group, and a high-risk group. Based on that, this competing risks regression model was published. If you have a low-risk patient, the recurrence risk is 9%. A moderate risk patient, it is 25%, a high risk patient is 46%, and based on that, we developed an algorithm. If you look at alpha-fetoprotein, UCSF, and FDG18 PET avidity, if it's a low risk patient, you go ahead with upfront liver transplant. If it's a moderate risk patient, you do downstaging and bring him to a low risk. If it's a high risk patient, there is no question of doing upfront liver transplant. You try to downstage and transplant them only if they get converted into low risk. Based on such studies like ours, and of course this paper was quoted there in that BCLC 2022 update, this is the first time after 2 decades that transplant has come into intermediate stage HCC from the BCLC. This was never ever accepted before, and they were forced to accept it now, I think because we have to give better outcomes in patients with HCC. So for a transplant physician and surgeon, what does downstaging mean? This is a short question, a short answer. Patient who was initially outside conventional criteria, bring them into transplant criteria. Or a patient who is having a high chance of recurrence, you have a low chance of recurrence, and that for me is true transplant success. And that is what is defined in BCLC as downstaging and stage migration. If I was to show you using our own algorithm, you convert a patient from moderate risk to low risk, you are able to transplant him within your criteria, and you have a low recurrence. Same way if you convert from high risk to low risk. And this is downstaging and stage migration. This is a simple concept. Therefore, if you were to ask me intermediate stage HCC, if they are extended criteria, you have downstage them, they are within your criteria, you can transplant. And here is the stage migration. If you are able to downstage them using TACE, and I think TARE is a very, very important modality, this is treatment stage migration, and you can transplant them with best outcomes. So this is something we already had said before in Puri 2 and Puri 3. We have emphasized on this, like Dr. Acharya said, that even if you have beyond explant criteria with no extrahepatic disease or vascular invasion, you downstage them and transplant them. This advanced stage is something that I want to talk about. You look at this and they say portal invasion and or extrahepatic spread. How many of you in the audience believe that portal invasion and extrahepatic spread is the same thing? Definitely they are not. They are completely different entities. Portal invasion is a local spread of the tumor, whereas extrahepatic disease is a systemic spread of the tumor. And therefore, you cannot club them together. If you have a large HCC with portal vein tumor thrombosis, lightning strikes, both for the patient as well as for the physician. For the patient, because he knows it's the end of the road. For the physician, because he doesn't know what to do. No one gives him any option. Palliative treatment, 3-year survival of 10%, 1-year survival of less than 20%. So no one knows what to do. And they give up. They give up because they already think it's a systemic disease, and no guidelines, whether it is ASLD, EASL, everyone says contraindication for TACE, contraindication for resection, contraindication for liver transplant. What should I do? I have no options, so I give up. I think we should change. These grades, Dr. Acharya has already spoken about. There's something called segmental PVT and lobar PVTT, and I'd like you to go back and read these two terms, or this is very simple to understand, but again, these are very different entities. A segmental PVTT, which is VP1 and VP2, has a much, much better prognosis as compared to a VP3 or VP4 tumor thrombus. We started working on this way back in 2013. I presented this in 2015 in Seoul at the ILDLT Congress. Just 13 patients who had VP2 tumor thrombus. We did not do any downstaging in them. We had to transplant these patients because they had a bad liver function. So they would have died without a transplant. We transplanted them. We looked at their results. Look at that. A 3-year survival of 72%, recurrence-free survival of 71% at 3 years. Would you deny these patients a transplant? I don't think you should. They would have had a worse outcome if you had, definitely worse outcome if you had not transplanted them. And then these two papers came in from Korea. This is from Seoul National. This is from Samsung. They again showed that if you have a segmental PVTT, you should transplant them if you have an alpha fetoprotein less than 100. This paper from Seoul National showed that you could still get a 5-year survival of 64%, even without downstaging in patients with macrovascular invasion. And the bad prognostic factors, again, were a lobar PVTT, a high alpha fetoprotein level, and a PET avidity of the tumor. Over the years, we found that there was excellent influence of radiotherapy in the treatment of HCC, whether it was SBRT or whether it was STAIR. And therefore, we thought also that we should not transplant them straight away. It's not a good idea. We should try to downstage these patients using radiotherapy, TACE or TAIR, and then transplant these patients and see what we have. So we started a clinical trial in the department in 2015. We used a clinical protocol where we downstage these patients using SBRT and TAIR or TACE. And then after response to downstaging, we went ahead and transplanted them. This was published in Transplantation in 2021. This was with 25 patients. Today we have 36 patients who have transplanted like this. This is the protocol. I'm not going to go into detail. Probably I'd invite you to read this particular paper. Very important. After you have downstaged a VP3, VP4 tumor thrombus, you have to wait to see what is the progression of the tumor. So that's the natural time to progression, or the natural biology that you are going to know of the tumor by waiting, repeating the PET scan, knowing whether the tumor is static or not. These are just some images to show you. This was an FDG avid right portal vein tumor thrombus, post SBRT, complete disappearance of avidity. This is a tumor on the left side which was avid, disappearance of avidity. Also, enhancing tumor thrombus on the arterial phase. Now there is non-enhancing tumor thrombus. This was in fact a VP4 tumor thrombus patient, a main portal vein tumor thrombus, as you see over there. We transplanted him in 2017. Today is 2023. He's alive. He had 1 recurrence in the bone, treated with radiotherapy, and he's alive and doing absolutely fine at present. 5-year survival, VP4 tumor thrombus, post-downstaging treated and transplanted. These are our results. 5-year survival of 53% in someone who would survive 3 months if you were not to treat him. Recurrence-free survival of 52%. And if you were to remove the 2 patients who died in the immediate post-op, that was nothing to do with tumor, they died of sepsis, 57% survival at 5 years in 23 patients. So compare this to a 10% 3-year survival, 57% at 5 years, and you know that you have done something for these patients. Of course, there are caveats. Not all of them are going to be downstaged, not all of them are going to get transplanted. The conversion rate to transplantability using downstaging about 50%. You start with 100, try to downstage them to transplant 50, you will be able to transplant. liver function does determine the feasibility of downstaging therapy. So if you have a Billy of 3 or above, or you have 5 or above, you're not going to be able to treat them or downstage them. Adequate waiting period, absolutely essential, and how effectively you deliver the downstaging therapy matters. Everyone where I go around and present this tells me, you show these results, but our interventional radiologist is never able to achieve these results, or we are not able to achieve these results. How you give the dose, where you give the dose, how much of dose you are subjecting, whether you are inducing radiation-induced liver damage or not, by correctly calculating the non-tumoral volume of the liver, which should be more than 60%, only then you can effectively downstage these patients. And it's not only us, now even in the disease donor situation, you have these reports of downstaging portal vein tumor thrombosis and transplanting them. The first one was from Italy. This is a retrospective study, multi-center from Europe. And therefore in Puri 2, we said that separate the patients with only PVTT and no extrahepatic disease versus extrahepatic disease separately. And then the ones with PVTT do have transplant and resection options. We put in a statement for resection, we put in a statement for liver transplant, and when this comes out next month, I think in Puri 3, you all will be able to read it. Who are the best candidates? I think I've already told you who are the best candidates. With successful downstaging, they are even better. My last 4 slides are about a concept called transplant benefit. It's the gain offered by a liver transplant in comparison to best alternative therapy. That is the survival after liver transplant minus survival with best alternative therapy. Simple example, 40-year-old male, child's B, hepatitis B, 2 HCC nodules, largest 6 centimeter, outside Milan, outside UCSF. If you were to transplant him, his life expectancy at 10 years is 10 years. If you were to do a TACE, his life expectancy is 2 years. On the other hand, 65-year-old male, child's A, HCV, 1 HCC nodule, 4 centimeter within Milan UCSF, fit for transplant. But if I was to resect this patient, he would still survive for 10 years. So for me, I will resect this patient. There is no need to transplant this patient. So this is transplant benefit, and actually transplant benefit is highest in advanced HCC rather than in early HCC, because in early HCC you have other options. So therefore, if you look at the transplant benefit in our algorithm versus doing TACE or TARE, the benefit at 3 years itself is 27 months. And even in high risk group, it is 17 months. And the transplant benefit with PVTT tumor thrombus, 23 months at 3 years in patients who are actually able to undergo a transplant. So that's transplant benefit. But should we transplant everyone, saying that there is transplant benefit? My answer to that is no. It should respect the equipoise concept. And in the living donor, you have to remember there is a donor involved. So you have to have a triangular equipoise, not transplant everyone. We have to assess, reassess, and only then transplant. How far is never, is too far? I think these patients are never for liver transplant. Extrahepatic disease, upfront LT in patients with macrovascular, failure of downstaging, expansion of criteria doesn't conform to triple equipoise. Relative contraindications, VP4, very high levels of alpha-fetoprotein, PIVKA2 to start with. Last slide, I think this is today's day and age, transplant oncology. You need everyone to come together to decide what is best for one individual. You cannot make a hard and fast rule for everyone. So everyone needs to come together, and I think the multidisciplinary approach will help personalized therapy to obtain optimal outcomes in these patients. Thank you very much for your patient listening.
I think fantastic. It's a mind-blowing and lucid presentation, Dr. Prashant. You made us really proud of you. And I think it's a very excellent meeting because of the Puri 3 people sitting here. So Puri 3 recommendation of HCC, they are here so that you can discuss all issues. I think before opening it to the hall, Shobhik and Dr. Manoj.
Sir, you have mentioned your study that beyond UCSF, you did the transplant, the survival benefit is more than 70%. Recurrence-free survival after 5 years. Do you compare it with the Milan in and Milan out in this? And next is do all these patients downstage first for which actually out, Milan out or UCSF out? Do you downstage first, then do the transplant, or straight away go for the transplant?
So 70% recurrence-free survival is of the overall series, which includes beyond as well as within UCSF.
Okay.
The recurrence rate in patients who are beyond UCSF is 10% higher. Okay, it is 10% higher. It's a given. We know it from everywhere. So that's why I said that UCSF, within UCSF, is the safest patient to transplant. There's no question about it. But what we have done is that we've stratified them into low risk, moderate risk, high risk. Low risk is if you have only one risk factor, that means patient is beyond UCSF, or he's having alpha fetoprotein more than 100, or he's having FDG18 PET avid tumor, or he's having no risk factors, then you go ahead with upfront transplant. If he has a combination of 2 factors, then you downstage. And if he has a combination of 3 factors or alpha fetoprotein and UCSF, both of these are worse as compared to FDG18 PET in our series, then definitely no upfront transplant. You have to try to downstage, bring them to low risk, and then transplant.
And how much time you wait after downstaging? 3 months?
So after downstaging, 3 months is ideal, okay? But depending upon their liver function, we have to decide. Sometimes you may have to go ahead at 2 months. Yeah, so AFP and FDG18 PET, this is showing you tumor biology. They are indirect markers. Is 100 for recurrence, yes.
I think Dr. Goenka.
Prashant, excellent talk. My question is, you did mention about it briefly, that approach for LDLT and DCL has to be different. So if you have a patient, if you have a liver available and you have 2 patients, one with expanded criteria and one within the criteria, are we justified in giving the cadaver liver to somebody who has expanded criteria?
So
that's one. And
yeah,
one more comment.
Yes.
Is that when you have to downgrade, you talk basically about SBRT. So how do you choose between SBRT, TACE or TARE for downgrading?
Okay. So first thing, sir, DDLT, I will not list a patient who is beyond UCSF criteria. So my listing criteria for DDLT is UCSF. So I will not transplant a patient with expanded criteria. The second thing is that there's a difference between those without portal vein tumor thrombus and with portal vein tumor thrombus. So without portal vein tumor thrombus, our choice of downstaging is TACE or TARE. If you have an up to 5 centimeter tumor, we can also use SBRT. Studies have shown that the results are equivalent between SBRT and TACE. And we were a part of a controlled trial also, which is in process at present. If you have a portal vein tumor thrombus, if it is VP1 or VP2, that means segmental portal vein tumor thrombus, we choose SBRT. If it is VP3 or VP4, we use a combination of SBRT and TARE. Because TARE is good for the tumor and for the portal vein tumor thrombus, and SBRT is good for the portal vein tumor thrombus. So we always use a combination. So we do TARE1 followed by SBRT followed by TARE2.
Dr. Akash Roy, yeah.
As usual, excellent talk, sir. Just to take it, we are just focusing on locoregional therapies as a bridge to transplant for downstaging. But with new data of both immunotherapy as well as lenvatinib versus TARE data that's coming out, are we not going to consider even these agents, like there's a couple of VP, a large portal vein thrombus, you give them immunotherapy, downstage with either immunotherapy or systemic therapy, and then make them candidates to transplant? Are we also looking at an avenues like that?
Excellent question. In my protocol, which I did not describe, there is sorafenib and lenvatinib included. So during the period when we finish the TARE2 and we wait for the complete response, if they were previously on sorafenib or lenvatinib, we continue it. The problem with immunotherapy, and we are doing trials in that, I am also a part of a trial from our center, is that immunotherapy, the safety of it for liver transplantation is still a question. So there's a very high chance of graft failure and graft rejection after stopping immunotherapy if you do not wait for a minimum period of 2 months. And all HCC patients don't give you that chance. So we are still looking at safety data, and that's why we have to wait.
Dr. Ashish.
Based on your talk, are you refusing any transplant to any patient if there is no extrahepatic spread?
If there is?
If there is no extrahepatic spread,
yes.
Are you refusing transplant to any patient?
Yes. Upfront transplant, refused.
No, I mean
overall.
Overall.
Yeah. See, I think there is a concept called all comers in the UCSF, which is now accepted by UNOS. You try and do the best for all comers with everything. If you are able to downstage them and bring them into your conventional criteria, then you transplant. But you will lose 50 of them. You will not be able to do. So what Dr. Acharya said, I think I completely agree with that. We have to try to cure all the patients. We may be able to cure them only in 40% of cases. But the attempt at the start should be intention to cure. So we cannot transplant everyone.
Thank you, Prashant. Really fantastic learning from all of you. On behalf of my co-chairs, we close the session here and hand over the mic to Dr. Achi. Thank you, Prashant.
Thank you.
Fantastic.
Thank you.
So moving on to the next session, that is on loco-regional therapy. I would like to invite our moderator, Dr. Karambir Chakravarti, to come to the dais. And for the chairperson, I would request Dr. Bhaskar Bikash Paul, Dr. Abhijit Chaudhary to join in the dais, and Dr. Dipanjan Panda. So, Dr. Karambir to invite the speaker.
Sure. Yeah. I think after the excellent talks of the surgery and of course how you diagnose the patient early, I think another most important subject, and as you see for downstaging, so really the loco-regional therapy is most important. It seems pivotal, and therefore this lecture is as well pivotal. I would definitely ask Dr. Usha Goenka to discuss about it. She is the director and head of the Department of Clinical Imaging and Interventional Radiology at Apollo Clinicals. Usha Goenka, please.
Yeah, pointer दे दे ये वाले
Yeah, whilst Usha is getting ready, I think I am sure Prashant would be saying, wish I had more liver to transplant. That's one thing which is very important in our country. And also, with the in the background, this development and important developments coming up with the systemic therapy, I think loco-regional treatment becomes more important, and that's why probably today's lecture is going to be pivotal.
A very good evening to all of you here. Thank you, Dr. Karambir and chairpersons. It is very obvious from the previous lectures that liver resection and transplantation are the ideal curative options in HCC. But these may be unrealistic for many, because only few, despite the liberal criteria as mentioned by Dr. Prashant, there are few people who may be fulfilling the pre-op criteria, and the recurrence rate of resection is high, and once recurrence occurs, the overall survival is a little poor. Also, that despite the increasing awareness and the more liberal transplant criteria, there are few centers which carry on transplant, and there is a chronic shortage of the donor organs. So it is this need gap which is very well filled by loco-regional therapy of HCC. These are minimally invasive image-guided procedures. They are very well established and universally accepted in the management protocol of HCC, and almost 60% of HCC patients would receive these in their lifetime. So my topic today is, rightly, recent advancement on loco-regional therapy for HCC. In the next 15 minutes or so, my agenda would be to tell you what is the objective of loco-regional therapy, what are the types, a brief overview of each with the advantages and limitations of each of them, which LRT to use and when, and how to assess the treatment response. So what are the goals of locoregional therapy for HCC? It could be curative, wherein the disease is eliminated completely. It could be downstaging. We have heard about it in Dr. Prashant's lecture again and again. It means to reduce the tumor burden so that the patient can be enlisted in the transplant list. It is bridging, it can help in bridging the gap in which the patient is waiting for the transplant and the tumor should not progress. So LRT can help in controlling this tumor progression. It can help in debulking. A reduction in tumor burden in advanced disease can prolong the survival, and it could also be used as a palliative technique wherein the symptoms are alleviated and it improves the quality of life. There are various types of locoregional therapy which is used, and these could be categorized into ablative techniques, transcatheter therapies, and radiation therapies. I will be first talking about the ablative techniques. Some form of energy is used in the percutaneous ablative techniques, which could be thermal, non-thermal, or chemical, and these cause cellular damage and tumor necrosis. This is easy to use in skilled hands and is cost effective because a large number of times it could be either done on an OPD basis or a very few in-hospital days would be required. Presence of active infection, extrahepatic disease, and decompensated cirrhosis, especially in presence of ascites, could be contraindications. And if chemical agents are used, it's chemoablation. If thermal agents are used, it's radiofrequency, microwave, HIFU, laser-induced thermotherapy. It could be irreversible electroporation and cryoablation. Radiofrequency ablation is the most time-tested percutaneous ablative technique. It's done under ultrasound or CT guidance. This is our intervention suite. This is the generator, the radiofrequency generator, which produces the high-frequency alternating current in the radiofrequency range. This is the electrode which we insert inside the tumor substance, and then how does this work? So this is the electrode. It will go into the tumor and tines will open out in an umbrella-shaped fashion like this. And once the alternating current is on, it burns the tumor. It burns the tumor and also burns a centimeter around it, giving it an ablative safety margin. Once the procedure is over, we bring the tines back and we take out the needle. And as we take out the needle, the tract is also ablated, thereby preventing inadvertent seeding of the tumor. So the best results are seen with tumors which are less than 3 centimeter in size, less than 3 in number, and they are well differentiated. But we have already heard that the criteria are becoming more and more liberal, and the radiofrequency ablation can be used in patients with larger tumors. A complete cure is achieved by RFA in well-selected patients, reaches to almost 100%. There are some limitations with radiofrequency ablation. The perivascular tumor, because of the heat sink effect, can be not treated completely, and the central part of the tumors after radiofrequency may show a complete necrosis, whereas the peripheral part may show patchy necrosis. RFA can also cause trauma to the adjoining vital structures, leading to biliary leak, stricture formation, or hemorrhage. A lot of studies have been done which compared the efficiency of RFA with surgery, And these are some of the recent studies, and it includes a systemic review and network meta-analysis. And the findings are that the overall survival, the cancer-specific survival, and the 5-year survival of RFA is similar to surgery. And in addition, RFA has a much lower perioperative morbi-mortality. Therefore, it's a safe and cost-effective alternative to surgery. Comparing chemoablation with RFA, chemoablation uses either absolute alcohol or glacial acetic acid. The limitations are that the chemical agent may not diffuse into the tumor substance in a very even manner, and there is no safety ablative margin, which means that the chemical agent diffuses within the tumor only. It does not go outside into the 1 centimeter safety margin, and the satellite lesions will also not be treated. But if cost is a factor, or the RFA and other ablative techniques are not available, a chemoablation is a good option in low resource settings and for small lesions near the vessels. Recently, people have used multi-tined infusion needles, which help in making the ablative area much bigger. So this is an example of 2 of our cases which we have done. The second one is using absolute alcohol, a segment 8 tumor showing the typical enhancement. We injected contrast mixed absolute alcohol, which is showing a good diffusion within the tumor. And this is the post-treatment CT scan, which shows a complete necrosis of the tumor. And the first case has been treated with glacial acetic acid. This is the typical hyper-enhancing tumor in arterial phase. The procedure was done under ultrasound. The needle in situ, these are the microbubbles which form once the chemical agent is infused into the tumor. And this is the contrast CT following the chemoablation, showing complete necrosis of the tumor with no enhancing nodule. Next, comparing microwave ablation with radiofrequency. Microwave ablation procedure is shorter, so it can be done under local anesthesia. It creates a larger and more uniform ablation zone. It's better for tumors which are near vessels because the heat sink effect is not much. There is no risk of burns, therefore the thigh pads are not used, and so it's a better option in patients with metallic surgical clips and pacemakers. This picture here shows microwave ablation producing a homogeneous ablation, whereas RFA, the central part shows greater necrosis and the peripheral part is showing a little less necrosis. A number of studies published recently have compared microwave ablation with radiofrequency ablation, and the results are comparable. There's no evidence of statistically significant superiority between these 2 techniques. However, more prospective trials are needed to comparing both the treatment therapies. There are other ablative techniques like cryoablation, which uses alternate freeze and thaw cycles. It's irreversible electroporation, which acts by disrupting the cell membrane, causing cell death. This is a very, very costly equipment, and I think there are just 2 or 3 centers in the whole country which do irreversible electroporation. HIFU, which was previously used for prostate, the use has been extended into liver tumors also. It uses low frequency, high energy ultrasound waves, and laser interstitial therapy ablation, which uses laser radiation causing thermocoagulation. However, the use of these ablative techniques is not a very common phenomena across the country, and therefore they have not yet been put as a standard of treatment. We now come to the transcatheter therapy. It's useful in intermediate stage tumors and advanced disease, and it acts by producing a cytotoxic effect by the therapeutic agent, which is embolized intraarterially, and also produces tumor ischemia. Extrahepatic spread, renal insufficiency, decompensated cirrhosis, and a very high bilirubin could be relative contraindications. The complications could be due to non-target embolization, which also results in a higher degree of post-embolization syndrome. It could be the conventional TACE, it could be bland embolization, which is a transarterial embolization. It could be DEB-TACE, and it could be radioembolization. Talking about conventional TACE, the first thing is a superselective cannulation of the hepatic artery branch. After that, a mixture of mostly doxorubicin is used. So doxorubicin and lipiodol is prepared with the help of syringes and a three-way like this, and then it is injected into the feeding vessel, and it goes into the capillary circulation, homogeneously spreading across the tumor interstitium. And once this is completed, the feeding vessel is also blocked using an Abgel suspension, which produces tumor ischemia. So in TACE, the action is by the cytotoxic effect as well as by producing the tumor ischemia. Comparing bland embolization with conventional TACE, in bland embolization, lipiodol and gel foam is used, but chemotherapy is omitted. So it could be useful in patients with heart ailments. Some of the recent literature published which have compared bland embolization with conventional TACE. So the results of the two are similar in terms of radiological response, progression-free survival, and overall survival. And bland embolization will have lesser side effects because no chemotherapy is being given, so it might be safer. However, larger multi-center studies are needed before a bland embolization can replace conventional TACE as a standard of care. Next, we compare DEB-TACE with conventional TACE. In DEB-TACE, biocompatible microspheres like these are used on which the chemotherapeutic agent is adsorbed, and it is dispensed as vials like this. The advantage is that it provides immediate ischemic effect because it is using particulate matter. There is enhanced tumor drug delivery locally. There is reduced peak plasma drug concentration, and therefore the systemic side effects are less. There is lower incidence of post-embolization syndrome. The risk could be biliary injury or liver infarction. The recent literature, most recent randomized trials have shown that there is no benefit of DEB-TACE over conventional TACE in terms of overall survival and progression-free survival. However, because of the several advantages which have been mentioned, DEB-TACE does have an edge over conventional TACE. Coming to radioembolization, it uses yttrium-90 loaded embolic microspheres, which once it reaches the tumor emits radiation inside the tumor and acts similar to brachytherapy. So the procedure is done in two steps. First of all, a planning angiogram is done. In this, we do a usual angiogram, keeping the catheter in the position where it would be finally be kept, and then we coil the vessels which can produce non-target embolization, and then we inject technetium-99m and take the patient for a gamma camera study, and this will reveal the shunting. Now, in this particular patient, most of the tracer is concentrated in the liver and very little is there in the lung. So, if the lung shunting is shown to be less than 20%, then the patient can be subjected to a radioembolization. So, once we are sure we want to go ahead and do a radioembolization, the tumor volume is calculated and the appropriate amount of Sersphere is ordered. And then on the day in which the procedure is done, the radioactive material is carried to the cath lab in a lead shielded container, and we fill it in a syringe and then we connect it to the catheter, which is placed super selectively into the tumor target branches. And then it's injected in the same way as we would inject the in a conventional TACE procedure. After the procedure is completed, a post-TARE SPECT study is done, and in this particular case, we are seeing that the concentration is very uniform in the liver tumor. Comparing TARE with conventional TACE, the advantages of TARE are that it involves fewer treatment sessions, there are less systemic side effects, it's well tolerated, and there's an improved quality of life. But it can lead to radiation-induced hepatitis and a non-target embolization to lungs, stomach, and duodenum could injure these organs. TARE allows a better local tumor control. Overall survival in several studies has been shown to be similar, and in presence of portal vein thrombosis, although TARE is very strongly advocated, but the prognosis is poorer when portal vein thrombosis is present. Now I come to the radiation therapy, though it's not in my domain, but I would still discuss one slide on that. So the various options of radiation therapy available for HCC are the stereotactic body radiotherapy and the external beam radiotherapy, particularly when it's intensity modulated. It acts by causing radiation-induced DNA damage of the replicating tumor cells. The advantage is that there is no size limit of the tumor which can be subjected to a radiotherapy. There's no local toxicity, there's no systemic side effect, and there's a good local control. It requires multiple sessions, and a tumor, if it's close to the bowel, cannot be subjected to radiotherapy because there's a risk of GI bleed and perforation due to bowel injury. The complications, if occur, can take up to 4 to 6 months after treatment, and these could be GI biliary complications and radiation-induced hepatitis. So this particular patient is, this is an MRI image after the SBRT has been done, and it shows a completely necrosed tumor. This enhancement is normal even if there is no viable tumor. When we follow up these patients because of the radiation-induced hepatitis. Combined therapy, we've heard, is coming up in a big way. It's useful for the intermediate tumors, 3 to 5 centimeters in size, and also it can be used for advanced cases, as we've heard before. It's the most common combination therapy is a TACE, followed by either RFA or a microwave ablation. And it is important that both the treatments are performed in the same admission, if not in the same session, because it improves the patient's compliance, because it becomes a little cost effective, and also, very importantly, the two treatments in the same admission would allow a synergistic effect. And it has been seen that the ablated volumes are larger, the oncological outcomes are better, there's less recurrence, and there's an increased overall survival. So this patient has a large tumor which was first subjected to a TACE, and then after the TACE in the same admission, it underwent an ultrasound-guided microwave ablation. So this is the CT scan, contrast-enhanced CT scan after the microwave ablation, and this is a coil which was placed intra-arterially because of some inadvertent leak during the angiographic procedure. So we have so many options in our armamentarium. It is but important that we should make a very logical and a scientific decision as to which of these should be used and when. So what we decide should be the appropriate treatment is based on the recommendations by the 2022 BCLC strategy. We have discussed it in detail, so I would not go into it. But the treatment is based or is dictated by these recommendations. I will just share a few cases which we have done. 63 years old female, she was a known CLD, had come for screening ultrasound, and here we can see a nicely encapsulated hyperechoic tumor on color Doppler showing a basket pattern, pathognomonic of HCC. This is the contrast-enhanced CT, arterially hyper-enhancing tumor with an early washout, again pathognomonic of HCC. So this is a single HCC, 2.7 into 1.9, with no extrahepatic spread, no vascular invasion, with a normal liver function test. According to the criteria, the best treatment is surgery or liver transplant, but the patient did not opt for that, so we went ahead with the ablative therapy. So this is the picture post-ablation after 6 weeks, showing the completely necrosed area, no enhancement, no viable tumor. And this is the CT scan done 3 months after the first scan. So here, RFA provided a complete cure. The next patient was an 83 years old female with HCC, and this was a larger tumor. This was an intermediate stage. So the treatment of choice would have been a loco-regional treatment, but we went ahead and did a radiofrequency ablation because that's what the patient wanted. And the post-ablation contrast CT shows again that there is no viable tumor. So in this particular case also, the RFA provided a complete cure. This was a 72-year-old female with multifocal HCC. The largest tumor was about 4.5 centimeters or so, and there were multiple smaller nodules. There was a small eccentric tumor thrombus also. The treatment would have been a loco-regional treatment. We went ahead and did a conventional TACE. This is the impregnated embolized material. This is a CT scan, which is showing lipiodol very well impregnated within the tumor, larger tumor, as well as in the satellite nodules. Now, this was a patient, known patient of chronic liver disease, who presented to us in our emergency with marked pallor and abdominal distension. This is the CT scan which has been done, a large tumor. There's an actual extravasation at the time of doing the CT, and there's a large hemoperitoneum. This was a ruptured HCC with hemoperitoneum, and we urgently booked a cath lab. We did a TACE procedure. In any ruptured HCC, the treatment of choice is either a bland embolization or a chemoembolization. A patient with advanced stage HCC, here we can see the tumor thrombus within the hepatic vein as well as the IVC, and the treatment is systemic therapy. We treated with sorafenib. Patient survived for 6 months. And the last case is a terminal stage HCC, an infiltrating HCC which was occupying almost the whole of liver. It's an end-stage liver disease. We provided supportive treatment. Patient died at 3 months. It is very important for us to know how to assess the treatment response in HCC. So the LIRADS has proposed that we should use a multiphasic CT scan or an MRI with using the hepatobiliary agent. This is important both for diagnostic workup as well as the follow-up assessment of HCC. And the follow-up imaging after ablation or TACE has to be done at 4 to 6 weeks and then 3 months thereafter. Whereas if it's a tear or a radiotherapy, then the follow-up is done after 3 months, because if done earlier, there could be confusing picture. So based on the imaging findings, the LR tumor response criteria are divided into 4 categories. The first is when it's not evaluable. The second is non-viable. There's no enhancing tumor which is seen, and or the picture is not same as what it was when, there is no viable tumor seen. The third category is a viable tumor when we actually see an enhancing nodule which shows the same characteristics of enhancement as on the pre-therapy CT scan. And the last category is the equivocal, when we cannot make a correct decision whether there is a viable tumor or not. So this is the MRI seen in a patient who was subjected to ablative therapy. This is the T1 weighted image. This hyperintense area eccentrically is due to presence of hemorrhage. And the next picture is a contrast enhanced MRI, which is showing the peripherally enhancing tumor. So this comes under the category of LRTR viable tumor. Summarizing, therefore, the treatment results in HCC have improved substantially over the last 2 decades because of better tumor-directed therapies and also because of the better management of the underlying liver disease. An early diagnosis is still the most vital factor for a good outcome. Loco-regional treatment plays a central role in the management algorithm of HCC. However, a multidisciplinary team approach is essential, with the treatment tailored to an individual rather than a prototype being followed. And it's equally important for us to know when to stop the treatment. And if we talk about future directions, the abbreviated MRI, which Dr. Abhijit Chaudhary had mentioned, is what is being proposed for follow-up, because this aims to decrease the patient discomfort of repeated imaging, and it also optimizes the cost but still keeps the image quality in mind. A contrast-enhanced ultrasound can be considered a cost-effective option and can replace a contrast-enhanced CT or MR. Fusion imaging with new tracers like a PET MR or a PET CT is being studied as new biomarkers. Radiomix and the artificial intelligence strategies, as again mentioned by Dr. Chaudhary, are emerging as potential imaging biomarkers. Thank you.
For an excellent overview. Any questions, Dr. Paul?
I would like to ask some questions. So one would be, when this is actually for the benefit of our, for the DNB and the DM students. Ma'am, when not to taste, I mean, what are the criteria that we should go about in, when to taste actually, or when not to taste?
Okay, so extrahepatic spread, when there is very high bilirubin, because the chances of the patient developing a liver failure and decompensation then becomes very high. And in our center, although portal vein thrombosis is considered a relative contraindication to doing a TACE procedure, but since we use a very super selective catheters in the form of microcatheters, if it is a subsegmental portal vein thrombosis, we do go ahead and do a TACE also.
Right. Abhijit, do you want to say anything? Dr. Panda, do you want to ask anything? Want to discuss? Now, the question is open to the floor. Yes. Dr. Ashish, yeah.
Excellent talk, ma'am. I just want one comment from you. You talked about all the loco-regional therapy in the liver. What about if there is some oligometastasis, single metastasis outside, like in lung or bone? Are there loco-regional therapy options for those metastases also, or in future can there be?
So if there are single solitary metastasis in the extrahepatic location, I believe, though I don't know what the literature says, but I believe that we can still go ahead and do the treatment which we have decided for the liver, whether it's a resection or it's a transplant or a loco-regional treatment. And for that solitary metastasis, we can go ahead and again do RFA if it's a solitary lung metastasis, or a kidney metastasis, or I don't know what the literature says, maybe. Or we can do a radiotherapy for that other lesion.
You can do radiotherapy, you can use radiofrequency ablation for oligometastasis, and I think Prasant does it. Prasant?
We've published our series on post-resection, post-transplant recurrence, and very clearly shown that if you have a use of combination therapy in the post-transplant period, especially with oligometastasis, and there's also a very huge study from Hong Kong who have published this recently, that oligometastasis is very, very different from multiple metastasis. Definitive treatment of an oligometastasis, whether it is resection, whether it is RFA, whether it is SBRT, definitely improves the survival even post recurrence after transplant. So we've done RFA of lung lesions, we've done SBRT to bone lesions, resection, VATS for lung lesions, and oligometastasis is definitely a different ball game, and I think you can really prolong survival if you are able to treat them properly.
I think I have one point to make. See, in oligometastasis, before giving definitive treatment, we must understand the tumor biology, which you have so succinctly said. So sometimes a tumor with very, very aggressive biology, if you try to treat them,
I'll tell you.
Definitely.
You see, many times the tumor biology because of oligometastasis may be marker higher. So remember, if you have a liver cancer, liver tumor, and you have completely treated it, whatever methods you say, but you see your alpha fetoprotein going, right? Your PET scan is not picking up. PET scan is a poor test for picking up marker. There is a metastasis. Now, if there is a metastasis, there are various ways to find out metastasis, right? So, if there is one metastasis and the tumor marker is going for that, you need to treat it. That is not a contraindication.
No, my only point is to sir that for an oligometastatic disease with an aggressive tumor biology, it may be more prudent to give a systemic therapy to look at the tumor biology and then do the definitive therapy.
No.
I don't think that it is right to wait and just give systemic therapy. You have to hit out hard. If you can see a metastasis, treat that metastasis and give systemic therapy. Okay. I'm on your side, Dr. Panda.
Okay. I think we can discuss it later on.
Don't allow him to die of a metastasis, oligometastasis. Okay. You see, there are treatment. So don't withdraw the treatment from him. You can combine multiple therapies. But question is whether you treat on oligometastasis. Tumor biology is a factor which these people use as a prognostic marker or outcome marker for transplant. It is reduced.
I think HCC and other cancers are slightly different.
So is it mandatory to biopsy the extrahepatic lesion because there could be metachronous or synchronous malignancies in the patients and it may not be a metastasis?
So I think if you do an RFA of a lesion, usually what the intervention radiologist does is at the same time he would biopsy and do an RF. If the imaging factor characteristics are very, very typical, you know, you've had a tumor, you have an increased alpha fetoprotein and you have a lesion which has come there either in the lungs or in the bone or in the adrenal, you know it's an HCC and you will ablate that lesion. Even if it was a de novo and a small tumor, you would ablate it if it was 2 centimeters. So I think you can do it at the same time.
Right. Okay, I just want one question. Yeah. After the RFA, do you find any recurrence later on? And what would be the incidence of recurrence depending upon the size?
So I had also mentioned about that in RFA, if the lesion is less than 3 centimeters, there is a very high probability of are completely ablating it, including the safety margin. But if the tumors are, because we extend the RFA to lesions which are between 3 and 5 centimeters also, there is a possibility that the peripheral part of the tumor might not be completely ablated. And that's where combination therapies come into picture.
Thank you very much. I'm sure you will agree it was a nice session. Thanks a lot.
Thank you, ma'am. Thank you, moderators and chairperson, for that excellent session and the discussion. Now we move on to the penultimate session where we would be talking about the systemic therapy for HCC. And for this, I would like to invite our moderator, Dr. Tarun Lahiri Majumdar sir, to come onto stage. And I would also like to invite our chairpersons for the session, Dr. Jyoti Ranjan Mohapatra, Dr. Srijan Majumdar, and Dr. Jayanta Mukherjee. So, Dr. Tarun, please.
Thank you, Dr. Ashish. So, all are well said? We have been listening to mesmerizing talks about several modalities of treatment in HCC. Somebody commented that in between there's a different type of tumor, and I agree. HCC is immunogenic tumor with angiogenesis. We have been talking about several treatments, but I feel personally that we are actually concentrating at a peripheral area of human body without concentrating about the very genesis of HCC. And here comes the question of systemic therapy, immune checkpoint inhibitors. And I'm sure we are going to get a different idea and a different angle of treating of HCC. And for this, we have to request Dr. Dipanjan Panda, who has got extensive experience in treating this disease. And he is the medical oncologist. He is a senior consultant at the Department of Medical Oncology, Indraprastha Hospital, Apollo, New Delhi. So, Dr. Dipanjan, we are going to hear something new and interesting for treating this challenging tumor, very difficult tumor.
Thank you, sir.
Thank you.
It's been an honor. I first heard you when I was an MD student way back in 2004 in Chennai, Gastrocon. So, can't help remembering the fact about 18 years back as an DM student at All India Institute of Medical Science. I was there from 2005 to 2010. In 5 years at IRCH, we barely saw 5 HCC cases because all the cases used to go to the next building, the main building where 4th floor, a doyen of hepatology used to run his HCC clinic, Professor Subrat Kumar Acharya. And 18 years down the line, I'm standing and giving a lecture as really we have come a long way. So, this is my declaration. So this will be the brief schema of presentation. I'll be talking about, I will not be talking but mentioning about the BCLC staging, which my previous speaker has so eloquently mentioned. A proposal for systemic therapy, the NCCN guidelines which we generally use. The first line systemic therapy, including targeted immunotherapy and combination, and what are the Inasl consensus statement and discussion. The second line therapy, a very brief discussion on upcoming treatment and summary. Won't be going into this. Professor Acharya has very eloquently talked about this, that the recent change after 2 decades, the BCLC has now divided the intermediate stage into B1, B2 and B3, and the advanced stage into C1 and C2. And this is the advanced stage which will be mostly discussion about the systemic therapy. And this has also been discussed. Basically the difference in the C1 and C2 is that the C2 is that extrahepatic disease with extrahepatic spread but adequate liver function. So this is very important, as HCC doesn't have only one disease, it is 2 diseases. It has got a bad liver and it is a cancer. And as an oncologist, I can say most of the patients sometimes die not because of cancer, but because of bad liver. So any medical oncologist, who are my teacher at All India used to say that you are first physician. So if he doesn't understand the liver, it is very difficult to treat the liver cancer. So this is the INSL proposal for systemic therapy. So which patients are the current indication for systemic therapy? So INSL BCLC stage 2, C2, Inasl BCLC stage C1, which are not undergoing transarterial radioembolization, B3, not undergoing tear, B2, who are refractory or ineligible to locoregional surgical therapy, and B1, who are refractory or ineligible to surgical or locoregional therapy. The caveat is patient with advanced liver disease with a CTP score more than 9. We are still using CTP. LB, I think, will take some time for us to digest, and is not recommended to use of systemic therapy. And this is the 2023 National Cancer Center guideline. This is in US guidelines, and this is more or less we follow. So the first line systemic therapy is atezolizumab with bevacizumab. Atezolizumab is an anti-PD-1 monoclonal antibody, and bevacizumab is anti-vascular endothelial growth factor receptor monoclonal antibody. There is also a newer data on tremelimumab and durvalumab, which are two PD-1 monoclonal antibody. And on the other recommended panel are the sorafenib, lenvatinib, durvalumab, and pembrolizumab single agent. And there are certain category where you can use nivolumab also. So we'll briefly discuss it. So to bring it down for students, these are the four group of drugs which is currently used for as far as medical oncologists are concerned. One is sorafenib, one is lenvatinib. These two are multikinase tyrosine kinase inhibitor. Why they are called multikinase? Because they prevent multiple tyrosine kinase pathways. And then there is atezolizumab and bevacizumab. I don't know why they make it such a jaw-breaking exercises. And there is also durvalumab and tremelimumab. These are the four trials: the SHARP trial, the REFLECT trial, IMBRAVE 150, and Himalaya trial, which will be. So we all know about SHARP. This is the first pivotal trial which took sorafenib as the first line of choice in an advanced disease. And it was 400 milligram BD sorafenib with, it was randomized against placebo. The primary endpoint was overall survival, adult patient with advanced HCC, child A, good PS. And the second point, so OS and time to symptomatic progression was primary endpoint, and secondary endpoint was time to tumor progression, DCR, and safety. This is the first trial which did show a statistically significant survival advantage. Let me tell you, it's not a good drug. Most of the medical oncologists agree that 400 BD is a dose that most of the Indian cannot tolerate. There are a lot of palmoplantar erythematosus or hand-foot syndrome, fatigue, hair loss, and weight loss, and it was a difficult drug to administer. But that was the drug which actually did show survival advantage not only in the European trial but also in the Asia Pacific trial, although the advantage on the Asia Pacific population was lesser. About 10 years after the SHARP trial, which put sorafenib in the chart of our treatment planning, came this drug, that is lenvatinib, which is another multikinase inhibitor. So this REFLECT trial, which took that patient with unresectable HCC with a BCLC B, which is not applicable for TACE, or BCLC C, child A patient. They were randomized to lenvatinib, 8 milligram and 12 milligram depending on the weight, that is less than 60 kg or more than 60 kg, versus sorafenib. So the primary endpoint was overall survival, but this was a non-inferiority study. So this was not a superiority study. They wanted to make lenvatinib as me too drug. And voila, in fact, it reached that primary endpoint, that it was found to be a non-inferior drug. It was the overall survival was 13.6 months versus sorafenib 12.3. But what is more important, that in the progression-free survival, it was actually found to be superior than sorafenib. And as a person who uses lenvatinib a lot, lenvatinib, as far as hepatocellular carcinoma is concerned, has almost replaced sorafenib as far as the medical oncologist, because it has much less side effect. It is better tolerated in most of the cases. So nowadays we mostly use lenvatinib as far as the drug TKI is concerned. So from these two trials, we concluded that sorafenib improves survival versus placebo. lenvatinib was non-inferior to sorafenib for overall survival, that increases response rates and delayed progression versus sorafenib. But by this time, we have understood that development of hepatocellular carcinoma has a lot to do with inflammation and immune pathway. So the most common progression of liver cancer is from chronic inflammation to cirrhosis and eventually to HCC. There is a sustained inflammatory response consisting of persistent oxidative stress. And we also know that the HCC develops through accumulation of somatic genetic alteration and epigenetic modification. And immunosuppressions may be one of the most important reasons, including T cell dysfunction, which occurs in the chronic infections and cancers. And there was also exhausted T cells, which will not be able to do an immune surveillance. So, and then the lab reports and the phase 1 trial shows that immune checkpoint inhibitors really work. I have some slides how immune checkpoint inhibitors work, but I think because of lack of time, I really omitted them. And we also get to know that immune checkpoint inhibitors not only works alone, it can also have a complementary and supplementary effect when it works with either tyrosine kinase inhibitors or anti-VEGF therapy, because anti-VEGF or hypoxia-inducing factor alpha can cause an immunomodulatory effect. So there are 4 major trials which in the first line they checked for immune checkpoint inhibitors. One is Checkmate 459, which is used single agent nivolumab versus sorafenib. Unfortunately, the predefined threshold of statistical significance was not met. IMBRAVE 150, which shows increased overall survival and progression-free survival with atezo plus bev, which we will discuss in detail. I will also discuss briefly Himalaya trial, which has recently published and shows that there is another first-line option which has shown superior overall survival benefit. And I will also very briefly talk about the LEAP 002 and COSMIC 312, mainly the lenvatinib plus pembrolizumab versus lenva, and cabozantinib and atezolizumab versus sorafenib, which both of them actually did not show overall survival benefit, but I believe we have things to learn from those. So this is Checkmate 459. The key eligibility criteria was advanced HCC, not eligible for surgery and or locoregional therapy, who has been referred to me by Prashant, albeit very unwillingly. Child class A, good performance status, systemic therapy naive. The objective, they were stratified according to etiology, vascular invasion and geographical area. To nivolumab, 240 milligram every 3 weekly. The dose of nivolumab used to be started with 3 milligram per kg, but now we have become a flat 240 milligram versus sorafenib 400 milligram BD till the unacceptable toxicity or disease progression. The primary objective was overall survival. The secondary was overall response rate, progression-free survival, and efficacy by PDL1 status. This trial, although did show there was a numerical superiority of sorafenib versus nivolumab versus sorafenib, but the predefined threshold of statistical significance or overall survival was not met. So we can call it a negative study. But the trial which actually changed the way we look at immune checkpoint inhibitor was this trial, which was published in 2020 in New England Journal of Medicine, was this paper, pivotal trial by Richard Fien, atezolizumab versus bevacizumab in unresectable hepatocellular carcinoma. So it's a phase 3 trial, first line atezolizumab plus bevacizumab. It's a locally advanced or metastatic or unresectable HCC with no prior systemic therapy, good number 501, stratified by region, performance status, vascular invasion or extrahepatic spread, and baseline alpha fetoprotein being less than or more than 400 nanogram per ml. Patient was, it was a 2:1 open label randomized trial with atezolizumab flat dose of 1200 milligram IV 3 weekly and bevacizumab 15 milligram per kg, which is pretty high. In colon cancer, we use it either 5 milligram or 7.5 milligram. But in ovary and now in liver, we are using that higher dose. And the sorafenib was in standard dose, and it was used until loss of benefit or unacceptable toxicity. The important point which I'd like to highlight that unlike the previous REFLECT study, it also included high-risk patient who having invasion of main portal vein, bile duct, more than 50% of liver occupying lesion. the co-primary endpoint was OS and PFS. The both group are quite suitably placed. They are equivalent. The age, sex, region-wise, about performance data, they were suitably matched. The majority of them are BCLC stage C, but there was also few patients of BCLC class A and class B. The majority of the etiology was hepatitis B of about 49% in atezolizumab and 46% in sorafenib group, followed by HCV, non-viral, the non-viral etiology about 30%. About 38% in the atezolizumab group have a high AFP of more than 400. 63% patient in the atezolizumab group and 56% in the sorafenib group has extrahepatic spread. Anyway, so the PFS did show there was a significant, statistically significant benefit of 4.3 months versus 6.8 months, and the hazard ratio was 0.59. That means there is almost 40% decrease in the risk of death. And median overall survival in the atezolizumab, which in the updated data is 19 months versus sorafenib in the 13.4 months, which is actually better than what we did see in the SHARP trial. It shows that our management of HCC and the liver has improved. If you look at this data that PFS and according to baseline characteristics, atezolizumab group was better than in most of the parameters, both in OS and PFS subgroup. And it also shows that complete resolution of tumor was quite significant in atezolizumab group. So 8% of the patient actually did show CR, which we never saw in any tyrosine kinase inhibitors. The toxicity is different. So whereas sorafenib has a diarrhea, fatigue, hand-foot syndrome are the major side effects, whereas in atezolizumab, it is the proteinuria, increased liver enzyme, hypertension, and of course the immune related reactions. They are the major side effects. So when you are using this drug, you must know what to do. So in conclusion, the IMBEV 150 did show that combination of atezolizumab demonstrated efficacy in patients with unresectable HCC. It demonstrated a statistically significant and clinically meaningful improvement in OS and PFS. Atezolizumab resulted in a clinically meaningful DNA deterioration. And this positive phase 3 data for atezolizumab highlights the benefit of targeted multiple steps in cancer immunity cycles and the potential to transform the current treatment paradigm. That's what the author mentioned. After that, there was this trial called Himalaya trial, which used multifocus study of tremelimumab and durvalumab in the first line therapy on unresectable HCC. Again, this patient has unresectable HCC with BCLC B or C, child A, no main portal vein thrombus. They were basically divided into 300 milligram single dose of tremelimumab and 1500 milligram 4-weekly durvalumab versus single agent durvalumab and sorafenib. There was another arm of 75 milligram tremelimumab that was closed, so I will not be discussing. The primary objective was OS and the secondary objective was PFS, ORR and duration of response. Again, this trial showed there is an improvement in median overall survival of about 16.4 months versus 13.8, which was statistically significant. So this is not the way we compare. There is no head-to-head comparison, but just for information, I would like to say that all this trial, the one thing we found that durvalumab monotherapy is also superior to sorafenib. But IMBRAVE numerically at least showed a better response compared to the durvalumab, tremelimumab, but that is a wrong way to see. They are not head-to-head trial. And the follow-up range of durva plus tremelimumab was much longer. It is about 33 months versus the atezolizumab about 15 months. So these two drugs are currently treatment of choice as far as the guidelines are concerned. And so if you consider these 4 major drugs which are available in the first line, you can see that compared to the TKI single agent, both the combination has a better overall response rate as well as I think the hazard ratio, better hazard ratio. I would also very briefly will mention about LEAP 002, lenvatinib plus pembrolizumab versus lenvatinib. The primary endpoint was PFS and OS. It was actually statistically significant, but unfortunately they did not meet the pre-specified statistical boundaries, so it was a negative study. The odd thing was, it was not that lenva-pembro did a bad job. It is actually the lenvatinib arm did an exceedingly well, and that's the trial was negative. So it did show that in some patients, that lenvatinib might show a very good response. 19 months is what actually atezolizumab was seen in IMBRAVE 150. Another trial of COSMIC 312, which shows cabozantinib plus atezolizumab. Cabozantinib is another multikinase inhibitor versus sorafenib. Again, the similar group of advanced patient. Again, it showed that there is a improvement in the PFS. Unfortunately, the overall survival benefit was not seen. So, summary of the trial in the first line, sorafenib is the sole approved agent initially since 2008. Then came lenvatinib, which shows the non-inferior OS and significant longer PFS. IMBRAVE study shows atezo plus bev has significantly improved the OS and PFS and has become the standard of care. The most frequent adverse event of atezo bev is hypertension and upper GI bleed. Himalaya trial demonstrated that tremelimumab plus durvalumab also is improved the OS with versus sorafenib, and durvalumab monotherapy was non-inferior to sorafenib. The choice between atezo-bev and durvalumab tremelimumab in first line remain unclear. However, in India as present, tremelimumab is not available, so I think that debate will take some time. LEAP 002 shows numerical superiority of the combined group of lenvatinib with pembrolizumab, but it did not reach statistical significance. COSMIC 312 did not show improvement in OS with cabo plus cabozantinib atezolizumab, and Checkmate 459 was a nivolumab. It did show some benefit, but it did not reach statistical significance. In the second line, there was 4 study of cabozantinib with Celestial study, nivolumab Checkmate 040, pembro of Keynote 224, ramucirumab Reach 2, which is a very specific subgroup, and regorafenib as resource. I will run through this. Resource was a drug called regorafenib, again a multikinase inhibitor, 160 milligram PO, very difficult, one of the most toxic drug I have seen, 21 days or every 28 days versus placebo. Although it did show an improvement in PS and PFS and OS, and is a second line drug once the patient progresses on either TKI or atezo-bev. Cabozantinib, on the other hand, as another TKI, which is 60 milligram dose against placebo, also showed an improvement in overall survival and progression-free survival. Again, the major side effect of it is diarrhea. We do not use it in 60 milligram. We start with 20 milligram, increase to 40, and most of our patients don't reach up to 60 milligram. Reach 2 by Andrew Zhu from Mass General Hospital shows that ramucirumab, which is like bevacizumab, is an anti-VEGF monoclonal antibody, just is the other subtype, the VEGF2 receptor monoclonal antibody. It also did show some benefit, especially when you look at an alpha fetoprotein more than 400 nanogram per ml. Keynote 224 did show that pembrolizumab with advanced HCC, which previously treated with sorafenib, can have some benefit. And Checkmate 040 had shown the doublet of nivolumab with ipilimumab, which is an anti-CTLA4 antibody, has improvement in overall survival. So these are the approved second line therapy of regorafenib, cabozantinib, ramucirumab, pembrolizumab, and nivo-EP. If the cost isn't concerned, then I think regorafenib and cabozantinib will score over most of them. So this is how we choose sequence of different therapy. If you have used prior sorafenib, we give regorafenib. If cabozantinib, up to prior 2 regimens, and patient is intolerant to cabozantinib. Cabozantinib is also can be used in a first line. The ramucirumab is only used when the baseline AFP is more than 400, and nivo and pembrolizumab has shown durable response. So the Inasl consensus on second line treatment is that the recommended second line therapy depends on the type of first line therapy. The first line therapy is atezo-bev, then tyrosine kinase inhibitors such as sorafenib, lenvatinib, cabo, or regorafenib can be used. However, if the first line treatment with sorafenib or lenvatinib fails, we can use second line therapy with either cabozantinib, regorafenib, ramucirumab, or atezo-bev. In addition, pembrolizumab and nivolumab are also reasonable second-line therapy. There is absolutely no role of conventional chemotherapy as of now. I put this slide so that any questions if they come. But I must say that role of chemotherapy in non-cirrhotic patient is not widely explored. It should be a part of future research. So this is the final INSL consensus statement which is coming in the publication. So in patient which systemic therapy is indicated, INSL recommends the use of atezo-bev as a first-line therapy. The level of evidence is high. In case atezo-bev is not feasible, recommends the use of lenvatinib and sorafenib, and that is going to be the majority of our patient. Atezo-bev is very, very expensive. Not more than 5% of our population will use. And we have seen, especially in non-viral etiology, tyrosine kinase inhibitors still hold strong. So please just do not go by the data. When you are practicing, look at the real life. There is no point the persons will be selling the house to use, getting a 6 months survival. Following the failure of first-line therapy and atezo-bev, second-line therapy with a TKI like sorafenib, lenvatinib, cabozantinib, or regorafenib may be recommended. And of course, if you have a sorafenib and lenvatinib in the first line, then you can change it. And ramucirumab is only used when there is a high AFP, very specific subtype. Pembro and Nivo are reasonable options in the second line following the first line therapy, especially with TKI. Use of bevacizumab, an anti-angiogenic drug, should be used with caution with patient with CVA, AMI, unstable angina, recent bleeding. And the patient with large, this is an absolute, if you have a large esophageal varices, please grade 3, grade 4, treat them, make him grade 1, grade 2, only then you start with atezo-bev, otherwise not. And non-viral HCCs have less advantage with immunotherapy. This is a proposal by Richard Feen, how to go about BCLC. So if you look at it, high risk of variceal bleeding. If no, you can go with atezo-bev. After progression, lenvatinib or sorafenib. If yes, then you can contraindication to checkpoint inhibitors, then you can use lenvatinib or sorafenib here, or otherwise you can use durvalumab or tremelimumab if there is a high risk of bleeding. These are the ongoing phase 3 trials. So we are using atezo-bev as an adjuvant, durvalumab with bevacizumab. In MRL2, I was a part of that trial. That data is still out. I think it will take a year or so to come to that primary endpoint. And there is also some trial called Keynote 937. So as what we've done, we generally use from metastatic to adjuvant and then neoadjuvant. That's how the oncology drugs progresses. So the drugs which have already shown effectiveness in metastatic setting, now they are being tried in the adjuvant setting. So we are also using loco-regional therapy with immunotherapy. So this is my summary and conclusion. HCC is a malignancy with high fatality. And it is somewhat preventable disease, and that part I think need to be really pushed, especially the vaccines and the diabetes control. Underlying liver pathology makes this management challenging. So the multidisciplinary approach is the key. The treatment option in advanced stage is expanding. The introduction of immuno-oncology in the frontline setting is definitely practice changing, and immunotherapy in combination with VEGF monoclonal antibody as of date remain the first line. However, not every patient will be a candidate for IO combination. In a resource-constrained country, TKI will continue to remain standard of care. Consider TKI or single-agent immune checkpoint inhibitor for those patients. And recent data with single-agent TKI has demonstrated a clinically meaningful change. Studies evaluating the role of IO in earlier stage disease are ongoing. I didn't talk about neoadjuvant because I think the data is still immature. Universal vaccination and aware among people essential for prevention. And I strongly believe that translational research with interdisciplinary cooperation is the need of the hour. This is the photo I took from INSL 2013, about a decade back. So I think, sir, we have come a long way, Professor Acharya. Thank you. Sorry I took it for 2 minutes extra.
Thank you, Dr. Panda, for giving us an overview of a journey with sorafenib and now with TDs to MABs. And I'm sure there will be a lot of questions.
Yeah, I would have really talked about the mechanism behind it, but I think it itself is a whole talk how it works.
here. I think from the chairpersons first, and then I'll go to the floor.
Excellent talk, sir. So, pending further data, what is your take on adjuvant chemotherapy or immunotherapy right now, as of today?
So as you see, our transplant surgeon always sends us a patient that this is a large tumor, we have resected it, but I am sure this will come back. And that brings us a very difficult moral, ethical, and sometimes a legal issues. Because no study with TKI has shown any benefit. But you must understand the STORM trial was with sorafenib. After that, few other drugs. Now, I think after the Emerald 2 comes, we will be wiser. But as of now, there is a case to case. If there is a very large tumor and there is a close margin, high AFP level, we generally give them lenvatinib, but that's not for the students. There is absolutely no data to support. But in real life, sometimes you use them, but whether it benefits or not, nobody knows.
I think we have sorafenib and livertinib, but rest of the drugs, are they available in the country, or we have to import?
Yes. As I have told you, sir, as I have mentioned, the data on immune checkpoint inhibitor in adjuvant therapy ongoing. So the Emerald 2 trial, which have used durvalumab, so they have given it for 1 year as an adjuvant therapy versus placebo. The only thing is that will take, I think, 1 year or so follow-up to come out. The problem with HCC, unlike other therapy, is that there are two. One, as a malignancy, it is relatively slow growing. There is less tumor division, so that conventional chemotherapeutic drug doesn't work. And there is also a factor of underlying liver disease, which makes the drug toxicity also a bigger issue. So I think I am a little, sort of skeptical about how well the adjuvant therapy will work. But this immune checkpoint inhibitor has made a paradigm shift because of the factor of memory T cells. They upregulate the immune system, and we know that HCC is basically has a lot to do with immune dysregulation. So because of this memory T cells, because the constant upregulation of that, development of future HCCs might be prevented by using this. But that is an altogether different area of research and discussion.
Thank you. It's open to all. We'll allow only one question. There is a shortage of time. Only one question.
If there is a question, I will sit down, sir, because I wanted to make a comment. If there is any question, I won't ask the question.
No, you please make a comment.
Yeah, thank you, Dr. Panda. I think that was an excellent talk. I think Sir's question, Dr. Mazumdar's question, was whether these drugs are available in the country.
I missed that.
So
yes,
everything is available.
Most of them except tremelimumab is available, and that will also be available in a couple of months. So in a way, we are extremely fortunate in India. We have a very robust domestic pharma industry, and because of a big market, most of the pharmaceutical company wants to come. And the regulatory affairs has also become more or less streamlined. But the biggest problem is the cost. The cost is really, really high, but over time the cost will come down. When I remember when I started my residency, rituximab used to cost 500 milligram, 1 lakh rupees in 2005. Now you can get 500 milligram rituximab in 5,000 rupees. So cost will come down.
So the reason why I was saying was, sir, everything is available. Atezobev is available, nivolumab is available. What is happening practically in India is people cannot afford the drug. CGHS and ECHS are giving approval to the drug. So studies are being done in India because they are getting the drug for free, and the government is supposed to pay for it. I feel that it is a duty, like Dr. Panda said, we should not use the drug right, left and center. We should not use Atezobev right, left and center just because we are being pushed by some trials which are coming from the West, just because we are being pushed by companies. We need more safety data. It is going to make a big difference. I was at the ILTS in Rotterdam recently, and Hong Kong group was presenting a study where they used neoadjuvant atezo-bev and radiotherapy to downstage resectable patients of HCC. I think I asked him the question, why are you using drugs when you can actually go ahead and resect? Is surgery now become second line? So I think we are getting pushed more and more to sometimes use this drug which is unnecessary.
Prashant, I will say.
No, let me just finish my comment. I'm saying I'm on your side. And I feel that it's going to make a big difference. Atezo-bev is going to make a big difference in the future. Like someone asked me about transplant. I said that till now we don't know the safety of using it before transplant because there's a very high risk of graft rejection, graft failure. And even if it recurs, there is a lot of question of whether it is safe to use it because you give rise to a lot of graft rejection, graft failure. So it will make a difference, but I'm not sure whether we should push curative treatments to second line like resection and transplant and try to use atezo-bev as first line. This is just a comment from my side.
Can I answer that?
Thank you.
Can I answer?
There is no question here. That's his comment.
Okay.
No, you have to accept that. It's a very valuable comment.
No, I have just one comment to make, but I'll answer the question. Yes, please.
So my question to you, Dr. Panda, is that, so in which patients, just like in IBD, we know that the biologics, so are there any criteria that we can say beforehand that these patients are not going to, respond to your immune checkpoint
Yes,
inhibitors?
so as
how
far
do you go about
HCC is concerned, we now know that most probably the patient who have got viral etiology works better with atezo-bev compared to patient with an NFLD. So people who have got NFLD as etiology, maybe I would prefer to give them tyrosine kinase inhibitor like lenvatinib.
You mean to say that that's only the criteria, that is viral, it's non-viral?
No, there are many other relative and absolute contraindication. Patient who have a grade 3, grade 4 esophageal varices.
No, I'm not coming to that. Before starting therapy, like some precision modeling, do you have any data as of now?
Dr. Paul, I would sincerely request you to discuss this issue during dinner time. Because, okay.
This is an important issue because it costs about 1.5 lakhs. So it is important to say.
Sir, one thing, always remember, the systemic therapy need good function and good liver. That's a very important thing. When you have good liver and good function, you actually try to provide curative treatment as Prashant was suggesting. When you are unable to provide curative treatment, you see, then only you think about this, and then remember, in a cancer patient, affordability, acceptance and costs are important factors. Now, Dr. Panda practices in a big shot corporate hospital where rich patients come.
Sir, it is not like that. 50% of my patients are poor.
So
to understand your age, if you have a bad liver, you won't be using it. No. You have to have a BCLC.
Please, during dinner time, please. These debates during dinner time. Thank you very much. This will never end.
Thank you, Dr. Dipanjan. Thank you, Dr. Tarun sir, and Dr. Srijan for this session. Now I would move to the last session where I would like to invite the panelists. I would like to invite the panelists for this session, Dr. Akash Roy, Dr. Jayanta Paul, Dr. Kingshuk Kumar Dhar, Dr. Shrikant Mohta, Dr. Partha Pratim Bose, and Dr. Sanjay Banerjee. Please come to the dais. I would like the panelists to permit me to start the session. So, in the last I would be discussing 2 cases, and I would be very fast. I would not stand between you and the dinner. So the case 1 is an 82-year-old gentleman. These cases are basically meant for mainly for the students, and these are simple cases. So he was a known case of diabetes, hypertension, coronary artery disease. He was stented a few years ago. He also had atrial fibrillation, for which he was on anticoagulants. And then he presents with pain, abdomen and weight loss for last 3 months. On evaluation, he had reasonable CBC. Bilirubin and albumin were okay, but ultrasound showed a cirrhotic liver with large space occupying lesion in the left lobe. Fibroscan was high, so he was clearly cirrhotic, and but CTP score he was reasonably preserved, 5/15. Alpha fetoprotein was markedly high, 90,000. PIVKA2 was also high, 2,800. So Dr. Akash, what next investigation should be done in this case? We have a liver sol in the ultrasound and high alpha fetoprotein.
Background looks like cirrhosis. We've got a liver sol which is already quite large. We'll be going ahead with the cross-sectional imaging. Our choices depends between dynamic CT, dynamic MR, or MR with the liver-specific contrast. Given the nature of the sol, it's quite a large sol. I think in a given regular setting, a CT would be given up with an MR, or a specific MR as an alternative option.
So, but clearly, if he has such high alpha fetoprotein as well as liver sol, so clearly it's a diagnosis of HCG. Do we still need cross-section?
We'll need a cross-sectional imaging that because number 1 to characterize the image, number 2 to see the extent, and number 3 to stage the disease that what we have all been talking about, so that we can choose the appropriate therapy that we are going to apply. So cross-sectional imaging is must.
So this is what also is mentioned in previous guidelines also in 2019, that dynamic CT or dynamic MRI is the recommended first line diagnostic tool for HCC. And the classical features are that in arterial phase there is intense hypervascularity, and then in portal venous phase there is a washout. But these features are only applicable if there is a background of cirrhosis. So what is the role of dynamic CT and MRI? As Dr. Akash mentioned, that HCC is the only cancer that does not need a biopsy for diagnosis, except for a special situation. So dynamic CT or MRI are enough. The other advantages of these dynamic CT and MRI is that we assess the tumor characteristic and we stage the tumor, so we can find out the tumor size, number, location, invasion of major portal vein. We also detect additional lesions which are not picked up by ultrasound. And if there's a high alpha fetoprotein or PIVKA levels due to cirrhosis then also we will know that this is HCC by dynamic CT. Also ultrasound sometimes give a misleading report. There could be regenerating nodules and not HCC. So this can also be clarified by dynamic CT. So in this patient, there was a 9 centimeter HCC in segment 4 of the liver, and also there was a thrombus in the portal vein, which was extending into right and left branches. So it was a case of 9 centimeter large HCC in segment. So Dr. Jayanta, what is the stage of HCC in this patient?
This 82 years gentleman is having hepatocellular carcinoma, which is around 9 centimeter in size in a cirrhotic liver with involvement of the portal vein, but there is no extrahepatic involvement. So if we follow this BCLC guideline, we can tell this is the stage C, means it is the advanced stage. But when we follow this INSL modification of BCLC guideline, then we can tell this is the stage C1, because there is no extrahepatic involvement.
Yeah, that's exactly correct. BCLC stage had actually clubbed both of them together. But as Dr. Prashant had already said, that you cannot club extrahepatic spread with the portal vein invasion. So according to Inasl BCLC staging, the BCLC C is divided into those having only portal vein invasion would be C1, and those having extrahepatic stage will be C2. So our patient he did not have any extrahepatic spread, so he belonged to Inasl BCLC stage C1. So, Dr. Dhar, so what are the treatment options now in this kind of patient situations?
Since we know that the patient is in the advanced stage, that is C1, and the tumor size is high, the options we know the several options like ablative therapies, but it is contraindicated in these patients. So the other therapies, resections, that is not possible. The patient is cirrhotic, as the investigation suggests. Then liver transplantation, that the criteria, Milan's criteria is not fulfilling. The others, all criteria are not fulfilling. So patient is not fit for TACE, only tear and SBRT is possible in this patient. To some extent, systemic therapy may be possible in these patients.
Yeah, so Inasl guidelines, actually this has already been covered, so I would not go into details. So resection, as you mentioned, in this patient which is already having clinically significant portal hypertension as well as portal vein invasion, so this is contraindicated in this patient. Liver transplantation, he is a not good candidate with such high alpha fetoprotein level. Ablation is not possible with such a huge lesion. TACE is contraindicated due to main portal vein involvement. But the only treatment options remain are tear as well as systemic therapy, and then there could be some role of SBRT, but alone it might not work. So in this patient we planned systemic therapy, and then we also planned SBRT for portal vein tumor thrombosis, because for portal vein tumor SBRT is a good option. So what is stereotactic body radiotherapy or SBRT? It has already been covered by Dr. Usha Goenka, that we give radiotherapy in a concentrated way to a focused radiotherapy is given, and so it's the same thing which we used to do for brain tumors, that was known as gamma knife. So this is same as now we are doing for liver tumors, and SBRT is a promising modality with good results for HCC. The median control rate is up to 90 to 100% in these tumors. The dose is 40 to 50 gray divided into 3 fractions, and it is a very good modality for portal vein tumor thrombosis, and there are many algorithms which have been proposed for SBRT when there is a portal vein tumor thrombosis. So tear, SBRT and systemic therapy are the options for this patient. But between tear and systemic therapy, which is better option, Dr. Srikanth?
So for our patient, since it's a main portal vein thrombosis, tear would also be a difficult situation. So I think there would not be much difference between both of them. And tear, if it was a VP2, VP3 or VP1 or VP2, definitely tear would probably be better. But in our case, probably both would have similar outcomes.
Yeah, that's exactly. There have been multiple meta-analysis which have compared tear with other options like TACE, and tear was compared to sorafenib, and tear with sorafenib compared to sorafenib alone. And it has been shown that almost all of those trials have shown that tear does not have any survival benefit as compared to TACE or systemic therapy, although there are few advantages of tear versus systemic therapy, but survival was almost same. So among the systemic therapy, the most promising and the best which is available is atezo-bevacizumab combination. The recommended dose of atezo is 1200 milligram, bevacizumab 15 milligram, which is given in the same day, and this is repeated every 3 weeks. But if for some reason, if we are not continuing with bevacizumab and we are giving only atezo single agent, then it can be given either every 2 weeks, 3 weeks or 4 weeks, but the dose would be different. So in our patient, we gave the first dose of atezo-beva, and we also planned SBRT. But 9 days later, he developed anal pain and fever. And the CT scan of pelvis was done, which showed a perianal abscess. So we interrupted further treatment and we started treating for the perianal abscess, and we did not proceed with the SBRT. However, while we were treating for perianal abscess, we repeated a CT scan about 3 weeks, and we found that compared to first CT scan, there was a significant reduction of the main tumor as well as a portal vein tumor thrombosis just by the single dose of atezolizumab. And there was a reduction in tumor enhancement also. And AFP also had declined within 3 weeks from 90,000 to 18,000, and then subsequently to at 5 weeks to 6,000. But the perianal abscess was a problem in this patient, so he received antibiotics, and then subsequently incision and drainage was done. But he had a complicated surgical course, so eventually surgeons performed a colostomy, which was about 47 days after the atezolizumab. But after colostomy, he started bleeding from the colostomy site, and which was also contributed by the portal colopathy he had. So he had a very complicated course. But by 2.5 months, he started improving. And then we decided to give atezo monotherapy, and we omitted bevacizumab because there was a high risk of bleeding due to bevacizumab. So with even atezo monotherapy, he had a good response, and there was by end of 2 months, there was significant decrease in the tumor size as well as the portal vein recanalization was there, and AFP levels also declined, and we continued to give about 8 doses, and the AFP had become almost normal. So this case showed that at least in this case, the atezolizumab had a very good response. So systemic therapy is indicated for Inasl BSCLC stage C patients, and among all systemic treatment options of first line, that means atezolizumab, lenvatinib, sorafenib, atezolizumab has got excellent anti-tumor effect, and at least in this case, there was a complete tumor response.
One small question. Was there varices?
Very small varices. So. Yeah, so large varices, if they are there, then that need to be treated before we start, because because of this there's a bleeding risk, increased bleeding chance. Yeah, cardiac problem is also difficult. So I'll, yeah.
More than 14 to 15 centimeters. Is there any criteria when you say if you treat locally, we have a liver failure based on the size of single lesion if it's more than 10?
Local regional therapy, for example, TACE would be contraindicated if it occupies more than 50 or 60% of the tumor volume, as Dr. Usha had already said. So there's a limit to which we can go in the local regional therapy. If there's very huge tumor, then tear could possibly be done, or the systemic therapy.
And one more. Suppose if patient's bilirubin happens to be around 3, with the rest of the liver functions are fine. So what options do we have?
So all the systemic therapy that has been recommended is only in child A patient, or at the most CTP score 8. But as soon as we cross 8 and CTP becomes 9, then most of these treatment at least can be done only on clinical trial basis and cannot be recommended at present. Yeah.
So it is true that in most of the trial setting, they have looked at not more than 1.5 times of the upper limit of normal. But we, in real practices, we generally see these patients who comes with a bilirubin of even 4, 5. So in that way, TKI is actually less safe than atezolizumab. So you can, I have used atezolizumab and bevacizumab in a bilirubin of 7 also. But you see, there is the student want to understand something. Immune checkpoint inhibitor does not work in every patient. In fact, if you look at all cancers, even a very high immunogenic cancer like lung cancer or melanoma, the response is in over 40% of patients. out of them 10% will have superior response and 20-30% will have a moderate response. In what way the immune checkpoint inhibitor is different? Because of the T cell upregulation and the memory T cell function. So it remembers. So when we give an normal conventional chemotherapy, once you hit, the disease after some time started growing. But we have seen with immune checkpoint inhibitors, even if you stop the treatment, the response may remain long time because of the memory T cells. So that is in a way fundamentally a different mean. But since the molecular crosstalk is more complicated than we understand, not all patient works.
So immunotherapy actually can be given in slightly worse situation also.
The only contraindication of immunotherapy is that post-transplant, there is a published data of 38% liver rejection. In kidney cancer, you can still give because you can put the patient on dialysis. In liver cancer, it will be difficult. So post-transplant. Sir, I'm trying to tell you that it is, I will not be using, but when you have no other options, sometimes patients are fit, you have only got a bilirubin assay. Obviously, if it's patient is on PS3, PS4.
But for the benefit of residents, bilirubin 7 would be very difficult, and we would not go beyond CTP 8 in general. So coming to the second case, he is also elderly patient, 63-year-old male, chronic alcoholic, and he presents with altered mental status for last 5 days. On examination, he had flapping tremors, and on evaluation, he was anti-HCV was positive, and also HCV RNA was high. Ultrasound again showed cirrhotic liver in the right lobe, and also there was ascites in this case, and small varices, but AFP was normal. The triple phase MRI was done. The non-contrast showed a 6 centimeter tumor in the right lobe in segment 7. Also there was ascites. The T1 weighted MRI in the arterial phase showed arterial phase enhancement of the tumor, as you can see here, and the portal phase showed washout. So basically it's a typical HCC. Single tumor on the right lobe, no portal vein thrombosis, no extrahepatic state, and also he has cirrhosis with underlying etiology of alcohol and HCV and decompensated cirrhosis CTP7, and ECOG performance status was 1. Dr. Bose, what is ECOG status? Can you briefly tell for the benefit of our residents?
ECOG is actually a measure of the performance status of a person who is having that cancer. This is according to the clinical oncology group, and they have been staged into the various stages. 0 is when the patient is totally with the cancer, he is able to do everything. Stage 1 is just mild restriction in the strenuous activities, but otherwise he is up and about and he can perform all light work. So in that case, here it's stage 1. Stage 4 is when the patient is completely bedridden, and stage 2 and 3 are when the patient is able to do a little bit of self-care, but he's up and about most of the 50% of the waking hours, and 3 is when he's confined to bed more than 50%. So this is something which is very important for management to see that if the patient is having a good performance status, that is lower scores, then he can be given a number of therapies.
Yeah, thank you. So most of the staging system now incorporate ECOG status, performance status, and there are many ways to assess performance status. One of them is being Karnofsky performance status. But for HCC, we generally use ECOG performance status, and most of the trials have used systemic therapy or most of these agents when the ECOG performance status has been 0 or 1. That means the patient is either fully active or only mildly restrictive. So, Dr. Sanjay, is the patient within Milan criteria or outside according to the patient which I showed?
Milan criteria which we all use for transplantation in HCC, I think this patient is not within Milan criteria because he has a single tumor which is 6 centimeters in size. Milan criteria is very good, I think. Since its inception in 1994 in Enigen, this has been extensively validated, and overall survival is 84% at 5 years and tumor-free survival is 75%. But at the same time, Milan criteria is too restrictive. And in a patient who is otherwise a good performance status, cirrhotic, single SOL, I think we must be more flexible or accommodative and adopt other criteria like UCSF could be as good for this patient.
Yes. So Milan criteria was proposed in 1996 by Masferrer et al. From Milan, which is single tumor should not be more than 5 centimeter, or if there are multiple tumor, they should not be more than 3 in number and all less than 3 centimeter. And he showed that the survival in this group of patient is better than those who are not meeting Milan criteria. So these have become a benchmark criteria, and patient transplanted fulfilling the Milan criteria have a 4-year survival rate of up to 75%, and then numerous studies have confirmed these data, and this survival of 75% at 4 years is almost equivalent to those who are transplanted for cirrhosis alone without HCC. But there has been many criticism of Milan criteria that these are too restrictive and only takes into account tumor morphology, and then patients beyond Milan criteria can be successfully transplanted, for example UCSF criteria as you mentioned, and up to 7 criteria. There are many other criteria, or they can be down staged to Milan criteria, and there are multiple expanded criteria. I am not going into detail so in our patient was beyond Milan criteria, but he fit into UCSF criteria. So Dr. Bose, should we transplant immediately or should we downstage this patient?
Now, in the LDLT setting which we have in India, so here we have beyond Milan criteria, but we have this patient in the UCSF criteria. It is 6 centimeter tumor, less than 6.5 centimeter single tumor will be in this group. So in this patient, we can go ahead with a liver transplantation immediately in this LDLT setting if it is available. And as far as downstaging of this tumor, since it's still within the UCSF criteria, maybe it's a bit debatable, but depending upon other factors, this patient is also hepatitis C, needs a bit of therapy, maybe for that. So we can consider that also.
Normal, 38. So tumor marker was 38. So the Inasl consensus actually mentions that Milan criteria are too restrictive and UCSF criteria should be applied and are the most validated. And in LDLT setting, Inasl actually recommends the UCSF criteria. And then, so in the DDLT setting, if the patient is within Milan criteria, if there's waiting period is too long, then we can go for bridging therapy. If it is beyond Milan criteria, then or even beyond UCSF criteria, we can downstage, then do DDLT. But in the LDLT setting, if it is within Milan criteria or within UCSF criteria, we can immediately do LDLT. But if it is beyond UCSF criteria, it is better to downstage, although Dr. Prashant had shown that some of these patients can still be transplanted if they have a better tumor biology. So after downstaging, we can assess for tumor response, and then if good response, then LDLT can be given. So in this patient, however, there was no transplant option at that present, so we decided to downstage this patient with TACE. And with TACE, after follow-up, he had excellent response. There was no enhancement. And then patient underwent LDLT about 5 months later when he was able to arrange for money, and then the donor was also ready. And just prior to transplantation, we did a fresh evaluation which showed that he was successfully downstaged to Milan criteria. The CTP score had increased to 9. But the HCV RNA by that time was negative with DA, and he was abstinent, and there was no extrahepatic stage. And now about 6 months post-transplantation, he is still doing fine. So learning from this second case, the downstaging enables a curative option for liver transplantation who would not have otherwise been eligible due to advanced disease, and downstaging selects the best cases that have good tumor biology. And downstaging HCC prior to liver transplantation can decrease the risk of post-transplantation tumor recurrence. So I would just end here. Any questions, sir? Any questions from the house for the panel? He would have transplanted directly.
Sir, I had one.
Yeah.
So I would do a case and transplanting of the 3 days. So what? So I think. So a patient within UCSF, the Inasl guidelines also say transplant. We would also transplant this patient. He's got among the 3 risk factors. He didn't tell us about the FDG18 PET. Dr. Ashish, was it avid?
No, not avid.
So not avid. So everything favors a good tumor biology. I would transplant straight away. Even for DDLT, he's within UCSF. I would list him and I would do bridging therapy. I would do a TACE in him in the waiting period. Whereas for liver transplant, I think with ascites, with liver function, which is already on the downward trend, he's almost B and going into C. I wouldn't really wait in this patient if he has a living donor. Go ahead with transplant straight away. So yeah, very important. I wanted to actually raise that thing, just to make a comment, because this should have come from the residents, whoever. Anti-HCV, HCV RNA is positive, or you have a hepatitis B patient with HCC, hepatitis B is positive. Should you previously treat the HBV and HCV before doing the transplant? The answer with today's anti-effective HBV, anti-HCV treatment is no, it's not required. The response rates are extremely good with tenofovir, with entecavir, and with your DAs. So there is no need just for anti-HCV or anti-HBV treatment to wait for the transplant, because he won't die of that, he will die of the tumor. So you can treat it after the transplant.
Sir, I have a question on this.
Only one rider. You see, if you subject, if it's a DDLT, you are doing a test, HCV RNA will go up. So in that case, you have to actually give the antiviral therapy.
I think this is
that is
still
only
not,
one rider.
So this would still not be clear. If somebody is on a treatable disease like HCV, and if it's a tumor which is like 3-4 centimeters, and either RFA or TACE, which shows a complete response on imaging follow-up sequentially, we are denying this patient of a cure for his virus for waiting for the transplant. If his child scores are going to improve, he might actually delist from transplant.
No, you're not denying the therapy. He's not denying the therapy. He's not refusing, he's not delaying the transplant. He's not denying the therapy.
Not at all. I would definitely start treatment for anti-HCV. Anti-HBV I would start after 1 week. Anti-HCV I would start after 2 to 3 weeks. So definitely I would start, no denying treatment, but you would not wait just because you want to treat anti-HCV, anti-HBV. That's what sir wanted to say, and I think that message should be clear. That and in waiting for DDLT, as Dr. Acharya said, definitely you should treat it. There is no reason not to treat it. But LDLT, then no need to wait.
What prognosis would you tell to the relatives in such a large tumor who is undergoing a transplant surgery?
So large tumor, it's a 6 centimeter tumor. So within you, it's a one tumor of 6 centimeters.
6.5, yeah, 6 centimeters. No, previous one was
no, previous
9.
one I would not transplant.
Because that 90,000.
No way I would transplant that patient. No.
So Dr. Prashant, one small question. Suppose the liver donor was ready, and in this situation within UCSF criteria, you had the transplant prospects ready. And instead of doing it right away, you just do a TACE and try to downstage that within UCSF criteria. And after that, you do the transplant after waiting for some time. So since the results are same with both these situations, so is there any increased vascular complications after this TACE followed by post-transplant? I mean,
so first, sir, I won't agree with the statement that the answer, the response or the outcomes are the same. Radiological response is not equal to pathological response in HCC. If you do a TACE in a 6 centimeter tumor, you are not going to cure the patient. So the curative treatment for him is a transplant. So you will not cure the patient. In the meantime, when you do a TACE and if you are waiting for 2 to 3 months, there is every chance that this tumor may spread outside and you may lose the chance of a cure. The second thing is that in a living donor liver transplantation, sometimes logistics play a major role. because you're talking about money, you're talking about available donor, fitness of the donor, everything. So sometimes, even though I would like, it doesn't give you the luxury of waiting for 3 to 4 months. In those 3 to 4 months, sometimes the donor may change his mind because of some family or some peer pressure from somewhere else. By the time he's done a TACE, that patient may decompensate, or he may have post-TACE syndrome. He may require 3 hospitalizations, spend another 6 lakh of rupees, and that 20 lakhs which he had in store depleted to 14 lakhs, he cannot have a transplant after that. So I think practically a lot of things go when you actually clinically treat a patient. So if you're going to give a curative option of transplant for a patient with a single HCC, 6 centimeters in size, I really would not do anything else, but I would transplant him straight away. Unless the alpha fetoprotein is very high, I would like to bring it down, PET-avid tumor, bad tumor biology, I would treat him, but otherwise I would transplant.
Do you see more chances of post-operative hepatic artery complications?
So nowadays, no. The intervention radiologists are very good and they do super selective. And we used to see this before, about 12, 13 years before, where, that artery was non-usable. Like, they go through the right artery, you don't use the right artery and go for the left when you're reconstructing. But nowadays, very low incidence of that. So they are very careful, they go very nicely with the catheters, and they do super selective inside the liver. So in that case, usually the arteries are okay.
Thank you. We'll end the discussion here. Thank you for your participation. So before dinner, I would like to propose a vote of thanks, and most importantly, thanks to all the delegates who have made this program a success. Thanks to all the faculty, speakers, as well as moderators and chairpersons for making this discussion very lively. I would like to thank the Maisha team for making this program flawless. Thanks to Inasl for giving us the opportunity to spread this in HCC symposium in all the 6 cities. And at the last but not the least, I would thank Roche for the educational grant they have provided. Thank you. Thank you for